Five,
चारों तरफ थोड़ा
four,
थोड़ा लगा दो,
three,
ज्यादा नहीं,
2, 1. We are live, sir.
इधर इधर इन चारों तरफ.
Okay, good morning, all dear friends from my country, from abroad, and those who are involved with us since starting, or you can say 1st of June 2020. And this is 29th webinar which we are conducting today, when they associated with the Thane AOI and under the Dr. Ashesh Bhumkar. And of course, Dr. Satish is the master today again. Thanks, Thane AOI. Thanks, all the panelists and friends. And today we are going with the highest version of the ENT surgery. Like many people are doing cochlear implant nowadays, and they are doing with different techniques, different mode of approaches. But they should also know the complications which they everybody or anyone can face in the future of the TI surgery. So first case would be about the how to manage the complication, how to salvage the implant if anything goes wrong with it. And second would again be with other options of the hearing, you can say aids or surgical option for those patients. So I think two cases would be the highest landmark today in our live surgical webinar. And again, I would like to thank Thane OI, Dr. Satish, and all the ENT fraternity, Dr. Venus, Dr. Selan Madam, Dr. Pooja, Dr. Ashish Boss, whosoever is there. So let's start. And I think Dr. Satish, Kitna sir is also there. Welcome, sir. Dr. Prakash Mukha sir is there. So all the legends are there, and let's start with wonderful
No,
discussion.
इसका फोटो लेके मुझे WhatsApp कर.
Ashish Boss, over to you.
No, hi everybody. I think
Good morning.
Yes, Satish.
Good morning, all. I welcome you again for this interesting webinar, and big thanks to Thane AOI for making this happen.
and morning
Dr. Sunil Budlani, Dr. Ashish Bhumkar for their continuous support. Thank you so much. And I am overwhelmed with the presence of Kirtne sir, who has always been a father figure for us, not only for cochlear implant, for overall, for many things. Everything in life, we always seek his blessings. Thank you, sir. Thank you so much. Thank you, Prakash Munka, sir. And we have very experienced, cochlear implant surgeon today with us, Dr. Shanal Kothari, who has a huge experience of having done over 500 implants and managing some of the important dreaded wound-related complications. Her insight will be very, very important today for our subject, the topic for today. Then we have Dr. Venus Patel, who has been, we have been part of our webinar as a eminent otologist. Thank you, Dr. Venus, for being with us. Sandeep and Udbhav have always been pillar for us in organizing these webinars, and of course, Pachori boss, who is the mastermind behind all this. Thank you, boss, and thank you all for joining today with us. And with us today,
Pooja.
welcome our plastic surgeon, Dr. Pradeep Goel, today, who has been kind enough to be part of this webinar and being here with us in our operation theater. He has been a source of inspiration for me. He has been a biggest, source for learning plastic reconstruction procedures for us. Not only for implant-based procedures, but other head and neck reconstruction, free flaps, and so many other. He's a master blaster in doing all this. Thank you, sir, for being with us. So today's first case, I know after this, I will take over.
Satish, please acknowledge Dr. Pooja Sancheti. She's going to be
Yeah,
moderating
Dr. Pooja Santeji, now I can see her on screen. Thank you, Pooja. She has been part of, advanced otology training procedures at Bhumkar Hospital. Thank you. Thank you, Dr. Pooja, for being with us. So, today's cases, like what I'm starting with, is an exposed infected implant, is a dreaded complication. And the second case would be taken over by Dr. Ashish Bhumkar, which is an interesting situation of same stage microtia reconstruction with hearing rehabilitation using a bone bridge implant, the ideal rehabilitation for such patients having conductive hearing loss. So that will be a treat to watch for all of us. Thank you once again. So, coming to the first procedure, can you connect this? This first case is a child who had been operated somewhere 1.5 years back. The surgical procedure went uneventful, and after some time, after a year or so, he started developing a post-oral swelling over the site of the receiver stimulator, for which he was drained by the surgeon thrice and was put on antibiotics. Repeated drainage antibiotic therapy didn't work, and ultimately the wound broke, and you can see the picture what ultimately happened. This is one of the dreaded complication of cochlear implant surgery. Ever since the cochlear implant has been introduced, it's been almost 4 decades from now. This has been a standard treatment for the rehabilitation of severe to profound hearing loss, and the indications have been expanding. More and more implants have been done worldwide now, and so far over 8 lakhs 800,000 implants have been done worldwide. Of the major complications, device failure, facial palsy, you know, this implant migration, and this implant exposure and attendant infection. This is one of the major complications of implant. And as the number of implants are increasing worldwide, so are the complications. And this complication can happen any point of time, immediately after surgery, some period after surgery, some weeks or months, or maybe years after the surgery, for many of the reasons which we are going to discuss today. This is an important subject for people who are doing cochlear implant surgery, to prevent these complications, to handle this complication once it happens to occur. This generally happens to occur in, depending upon the center experience, in 2 to 5% of the implanted patients. I know the experience is the key to prevent this complication and handle this, and we have one of the most experienced cochlear implant surgeons in the world, Dr. Milind Kirtanen sir, with us. We have Dr. Chanel Kothari with us. I was just discussing informally with Chanel madam, who has done over 500 implants and come across this situation in 11 patients, of which she has been able to salvage 7 and had to explant 4 out of them. Good morning, Paramita.
Good
Good
morning, sir.
morning.
Good morning, sir. Interesting cases lined up,
Nice
sir.
to
We'll
see
have a
you after a
great
long
discussion.
time.
Yes, sir.
Paramita has been a pillar of our series of webinars, and thank you once again for sparing your valuable time.
Thank you, sir. We'll be having a great day today because great cases lined up today.
Thank you. Thank you. So this is, as I said, as one of the dreaded complications which no implant surgeon would like to see, and no patients would like to bear such complications. So, as far as the complication prevention is concerned, surgical technique is one of the most important part we need to understand, and every step in surgery is important to prevent such complications. So surgery is one of the factor besides the patient factor, comorbidities, and so many other things. Comorbidities means post RT patient, post chemotherapy, immunocompromised, diabetic, smokers have more chances of developing such wound related complications in general, not for this implant particularly, but in general, all post surgery wound related complications are more common in those group of patients. As far as this complication is concerned, see, we put a foreign body in a patient, and any patient with foreign body in place, if happens to acquire infection, by and large, as a gold standard, needs simply explantation. With cochlear implantation, with a lot of costs involved, and the fear of taking away the hearing from the patient whose hearing is so crucial in developmental phase, all efforts are being placed to salvage these implants, to preserve the patient's hearing and speech development, as well as the attendant costs involved. There have been a lot of attempts, worldwide done, a lot of publications, you can see in the literature regarding salvaging these implants. A lot of people have introduced so many things to preserve the implants, and the biggest obstacle in such patients See, once the implant is exposed, the infection is, impending. And with a foreign body in place, the infection is more dreaded as it happens to acquire the biofilms. Biofilms, we all know, are nothing but the aggregates of bacteria, which by means of a different genetic, variation, they happen to acquire a polysaccharide shield around them. The bacterial colonies are surrounded by the polysaccharide matrix to protect them from antibiotics, to protect them from the patient's immune response, and those bacteria survive in that different, you know, profile with least action by the antibiotics and the immune system, and they keep on releasing virulent bacteria from time to time and give this dreaded infection. So biofilms are the most important, obstacles in these problems to deal with. And with the biofilms, with a foreign body in place, anywhere in the body, like orthopedics are using prosthetics or anywhere in the body, it simply requires explantation. But we have been able to salvage many of such implants, and this is what I am going to share with you today. So first of all, we'll discuss how we can prevent this complication. This is very, very important, and then how to manage. Management is simply four pronged. Whenever such infection or biofilm happen to take place, the first important thing is to start antibiotics, obviously, and most of the time it doesn't work. And if the implant is exposed, it requires immediate coverage to prevent the infection spread. Infection is spread to the implant itself. An implant being a foreign body with a lot of depressions and a lot of things over it, acquire biofilm so easily. So, as far the management is concerned, we need a good, solid, effective biofilm eradicating agents. A lot of agents have been, practiced across the world. We went through the publications earlier. One of the publications emphasized on the tea tree oil. Tea tree oil as a content which has a ability to kill methicillin resistant staph aureus, which is one of the most common agent in causing biofilms in implant related infections. We have been using, besides that, hydrogen peroxide, gentamicin wash, so many things, betadine wash, and now the most effective, I would say, the most dreaded agent to kill the biofilms on the planet is a manuka honey with a special content methyl glycol in it, which I'm going to demonstrate today. Then obviously these wounds are ischemic, infected, you need to debride until you get a fresh vascular surface, and then to cover it with a good vascularized flap to introduce new blood supply to make the antibiotics more effective in the new area free of infection and all those things, and then after followed by a long term antibiotic. This is the philosophy to combat this difficult problem most effectively, to salvage the implant, and we have been able to salvage almost 80% of the times our implant, functioning implant. So first of all, it is important to know whether implant is functioning or not, and then you have to exercise all this. And in any given unfortunate situation, you are not able to you know cure this problem. Cure means, in spite of having done everything, the infection reappears. Then obviously you're left with no other option than to explant, and that is a failure. And that still can happen in the best given conditions in any patient. Keithne sir, I know you must have been getting such patients referred from everywhere, as you have the busiest cochlear implant practice. How are you dealing this situation? Anything different or any suggestions?
Almost the same order that you suggested, that you have to try and get the biofilm. So if you expose the implant, you have to try and clean it up with some agent to try and eradicate the biofilm. A good wound debridement. I usually take a plastic surgeon with me who rotates a vascularized flap. You reposition, you recreate the well, and then you have the antibiotics to begin. So more or less exactly what you're saying, but I have not been as lucky as you in salvaging
Ajay.
80% of the implants. I would say it's much lower than that, because very often the wound seems to heal, everything seems to be okay, and then after another 3 or 4 months, the thing makes its appearance again. So I
Yes.
think in your hands, the results have been outstanding. We've had patients who have had the good fortune of successfully saving their implants, but certainly nowhere near 80%.
And sir, I what I
I
have
have not
realized,
used Manuka honey, so I have to,
yeah.
to
So
think about that.
what things which have impacted most in our practice are two things: the Manuka honey and the reconstructive procedure, the vascularized flap.
Yeah, that
With the
vascularized
help
flap, I
of
always have my plastic surgeon
yes,
coming along to do it
yes.
for us.
Earlier, I used to cover simply with a rotating superficial temporalis fascia or a posteriorly rotating scalp flap based on the occipital artery. Sometimes two flaps, sometimes the myofascial flap, including the temporalis muscle as well. Now, with the help of plastic surgeon, you'll see today, he has been, what he has been doing is rotating a composite flap, including the skin and the fascia, to cover the implant so nicely, very well vascularized. And what I believe now, this is should be the ideal choice to cover such situations. And second thing, which has had a big impact, is this Manuka honey, which is a solid, killer for the biofilms. Biofilms are difficult to diagnose. Number one, what you see intraoperatively, biofilms are like pale granulation tissue. It's a jelly-like material, which are basically bacterial colonies where the antibiotics do not penetrate. Difficult to diagnose and difficult to treat. Even if you diagnose, there are variety of biofilms in this prosthetic settings. Any prosthetic setting, it is the methicillin-resistant Staph aureus biofilms are commonest and most dreaded, most difficult to treat. Not the Pseudomonas. Otherwise, the Pseudomonas infection is more common in these situations.
Strap.
For this, no single agent has been very, very useful. Besides that, you don't know what exactly the bacteria involved in biofilms. So this Manuka honey, by and large, covers all dreaded biofilms, including MRSA, Pseudomonas, H. influenza, and all. So this is a one solution for all biofilms. Why we are using, and we have been acquiring this from New Zealand. Cost is one of the factor, and the laboratory which has been approved for the medical use of Manuka honey, which contains a specific dose of methyl glyoxal with a specific concentration, is a Watson and Hill laboratory, and you can acquire it through the Amazon or by any other sites on the internet, and you can get a home delivery. And this is one of the most important thing which has given us best results in these situations. Now, coming to the prevention of such situation, we always discuss during cochlear implantation, during surgical technique, what to do, what not to do. Like in the previous implant procedure, where we had Kirtner also in our surgical part, everything is important. Like Ashish Bhumkar, when he does pinna reconstruction, he always talks of vascularity around the pinna. That's the most important thing. Your simple incision is a very, very important thing. We should respect the vascularity all around the pinna. The region, periauricular region, is predominantly supplied by three vessels: posterior inferiorly occipital artery, inferiorly posterior auricular artery, and anterosuperiorly the superficial temporal artery. And the network of vessels arising from the branches arising from these vessels are responsible for vascularity around the ear. So our simple incision should respect the vascularity without cutting off any of these major vessels to prevent wound dehiscence and wound infection. Number one. Number two, the atraumatic technique of dissection is so important. We always emphasize on using less and less cautery, more and more, you know, the tissue respecting dissection. Third is less and less use of retractors, pulling the tissue unexpectedly and more, which is not required. Then raising the flap respecting the implant. The implant should not come under the stitch line. We always mention that the implant should be away from the incision line, so that in any case of wound adhesion, which is more likely less depth at the area of the suture line, The implant should not be underlying there. It should be away from the suture line. All these things are important because once if the suture happens to break, the implant gets exposed, and the exposed implant is something which invites infection. So all these things are important. The thickness of the flap is equally important. We tend to make the flaps relatively thinner because the magnet is going to come from above to contact the implant. So we expect a thin flap, thin scalp flap, but it should not be made too thin to be necrosed by the pressure of the implant and the magnet in the future. So all principles are important. Then how to fix the implant? Implant migration is one of the problems, biggest problems acquiring infection. A constant projection of the implant over the skin, the skull surface is one of the reason irritating the underlying skin. If the flap is too thin, it can break through. So nowadays, more and more slimmer profile implants are available as compared to the past, and wherein you make a good, well inside the skull to make the implant. To prevent the implant projecting from the surface, and all these things help preventing exposure in the implant, help preventing erosion of the skin by means of a projecting implant surface. And on the other side is a magnet above it, pressing the skin on both sides. That can lead to anything which results in, you know, compromising the blood supply, can result in necrosis and then invite infection. Suture material to fix the implant, there has been discussed a lot in the literature that we have been using proline to fix the implant, and that can acquire the infection. As such, proline is an inert material, doesn't cause infection. But if your suture, you know ends are projecting towards the skin, close to the skin, and happen to erode the skin, can be a disaster. So all those sutures, whatever proline or use, proline is not the problem. It's how you leave the ends of the cut ends of the suture which are important, and all those cut ends should be, you know, turned inwards and pressed with some agent so that it doesn't come in. They do not come in contact with the skin surface. So any foreign material contacting, eroding the skin from inside or from outside can result in erosion of the skin, necrosis of the skin, and result in implant exposure. People wearing post-implant, wearing the hats or sunglasses, pressing on the implant surface, can also be the cause of erosion of the implant. And this has to be very, very careful. One has to be very, very careful in situation where the patient has some or other background of immunocompromised situation like diabetes, smoking, and other things. Post-radiated, post-chemotherapy. So every surgical step in a regular implant surgery is important in preventing wound related complication and attendant exposure of the implant and the infection. Once it happens to occur, we are going to discuss now shortly then how to manage. And this is the classical example. In my practice, we have been getting patients from many places, and we have been able to do such almost 35 cases of salvage of the implant, and we have been able to manage many of them. Like Kirtnes has said, in spite of having done a good job, some of the patient, they acquire the infection again, and that is the most unfortunate situation, calling explantation. And that situation, one has to take a call of finally explantation. And in that situation, if it is always better to leave the electrode array inside the cochlea and cut the electrode array at the level of the round window to keep the cochlea patent, so that you can come back after some time once the infection resolved, after some months, to come back with a new implant, remove the electrode array that keeps the cochlea patent, that keeps like it works like a lumen keeper, and then you can insert a new implant into that. Or then, or otherwise, you go to the other side. If the other side, the patient has a bilateral profound loss and the only one side is operated, to go to the other side and rehabilitate the hearing early, then coming to the same side after waiting of so many months for the revision surgery. So a lot of philosophies, you can plan yourself according to the situation demands. Anything you want to add on, Kitnes sir, in prevention of infection?
Just one word of warning for people, that sometimes the patient comes away, from far away for this, and he says, "Sab bar bar aana, it's difficult." Avoid the temptation of implanting the other side at the same sitting. You have
Yes.
infection, and this has happened. You have infection in the body. If a patient had an abscess somewhere, you would not do the implant. So you explant on one side, and because the patient has come from far away, you're tempted to put an implant onto the other side. Please don't do it till such time that the infection has completely healed. This is a word of warning because I have seen patients coming to with the other side also now infected because the surgeon decided I would do both in one stage.
Yeah, that's a very important message which always tempts the surgeon to go to other side with the infection in place on the other side. So that has to be avoided. That's a very important message from sir.
No, it is because the patient pushes you into it. साहब इतना दूर से आना है, बार-बार नहीं आ सकते, please कर दो.
Yes.
Don't fall for that.
And in spite of
Yes.
whatever you do to salvage the implant, you can't promise 100% to the patient because the infection, the reasons for infection, and the situation which led to infection are sometimes beyond your control. We have seen patients who were implanted 5 years back and now come with the exposure of the implant for many reasons. So there are certain situations which are beyond your control and you can't promise your patient that how the results are going to be. Yes,
This
Deepak.
patient I have seen.
And I
This
would
patient I
like to
have
have
seen.
comments from Dr. Shanal Kothari as well. Yes, Deepak.
Satish, good morning.
Good
Actually,
morning, Deepak.
because you are here, Dr. Kirtane sir is here. I want to know, we all know this is the extrusion is one of the problem or infected implant is the problem. But as sir is so experienced in this field and you are so experienced, my question is, what is the role? We all know role is there, but the extrusion rate in your hand and sir's hand, because I always feel that the technique and the precautions we take in all the steps of the surgery, they prevent the extrusion in majority of the cases or protrusion of the implant. I want comments of sir and you, both of you.
Satish,
Yes, dear.
sorry, I'm going to make a comment before I get into the OR.
Yes,
And this
yes,
is
please.
about actually bringing the vascularity in that region on the forefront. I think, see, for microtia, we always mark the superficial temporal artery. There's a simple handheld Doppler that you have. Because this flap, the way you're talking that sometimes in spite of doing a good job, you still have breakdowns. This is because probably the vascular map of the superficial temporal artery has not been marked. And in the primary surgery, you have sacrificed inadvertently some branches. So I think just like in microtia and now today also in bone bridge, we'll show you the vascular mapping. If that flap can be preserved for a possibility of a later use, maybe the success rate will be better. I want to bring in that the superficial temporal, the temporoparietal flap has to be an integral part of an autologist thought process. Because when we take the temporalis fascia, we simply destroy that flap. I will make this point when I am doing the bone bridge. Sorry. Take over.
Just a small thing I wanted to ask Dr. Satish Ashesh. Out of the 35 odd case you get in a month for reimplantation, and what is the incidence of biofilm? Which biofilm is contributing to this? Number one. Number two, how earliest you can diagnose?
Hello.
Yeah, I asked for Dr. Satish, okay, what is the incidence of biofilm in your experience? Say out of 35 comes for revision, how much of this is because of the biofilm? Number one. Number two, how do you earliest diagnose that, yeah, it is a biofilm?
Yes. So, you mean to ask the incidence of biofilm formation post-implant surgery?
Yes.
See, biofilm will happen to occur once the infection sets in. Biofilm is not from beginning. Once the infection sets in the presence of a prosthetic device, it gives an favorable surface for the bacteria who assume a different phenotypic environment. See, how do biofilms form? Well, there are a certain number of bacteria fulfill a quorum. It's a quorum sensing mechanism. Can you
Yeah.
silent? quorum sensing mechanism for the bacteria to come together and excrete a polysaccharide matrix around them. They assume a different genetic condition which is metabolically different from that regular bacteria, and that metabolically different genetic condition saves the bacteria from the antibiotic treatment, from immune response, and they have a ability, they develop the ability to survive in the most, I would say, unpredictable situation. So that kind of genetics those bacteria acquire, in that shield of polysaccharide matrix, it keeps on releasing virulent bacteria from time to time. So number one, difficult to know whether there is a biofilm. Number two, difficult to know the which bacteria is responsible for biofilm, whether it is a Staph aureus or the Pseudomonas, which are the two
Pseudomonas.
threaded bacteria. How you can get to know? Number one, the infection which is not subsided with the best of the antibiotic, best of the culture directed antibiotics. Silent कर दो ना यार उसको. And how you can get to an idea by other means, as it's a biofilm, is to get repeated cultures. Once it releases virulent bacteria, you can pick up in between the offending bacteria and you can assume that to be responsible for the biofilm. In spite of the culture directed antibiotic, best of the culture directed antibiotic, if it is not coming under control, with a foreign body in place, it cannot be anything other than a biofilm.
Okay, so nicely explained. And what are the incidents in your cases? And other than CI, do you
Yeah.
get this
See, the incidence
condition?
is roughly, if you see the world literature, the incidence is
Yeah.
2 to 5%. It can be
Okay.
immediate or it can be delayed post surgery, but this can happen. And the incidence is roughly 2 to 5%. Are you getting the picture, sir? Oh, ye lagao na. Are you getting the microscopic picture?
No, 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 not
No,
yet.
sir.
Yes, sir.
No,
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 no, no,
Let me
sir.
know.
Not yet.
no,
No,
sir.
sir.
No.
Yes, now it is there.
Sir, there
Yes.
was a question that if the Manuka honey, will it compromise the area sterility, like of the operative field?
Not really.
Okay.
Manuka honey doesn't, give any harm or any negative impact. Are you getting the picture?
Yes, sir. Yes,
So
we
Yes,
are
this
getting
is
it.
the condition of this exposed implant. And this exposure is invariably associated with the infection. Number one. And see our planning. What our plastic surgeon gives us this amazing, way of covering this implant. And this is the simplest, I would say. What we have marked, like what Ashish said, is a very important aspect of vascularity. See this? This is the stem of the superficial temporal artery, and this is the frontal and the parietal branch.
Zoom out, please zoom out. Little zoom out.
Yeah, this is the frontal and the parietal branch. This is maxim with this microscope, and this is the skin island along with the temporalis fascia, which we are going to harvest.
So we are going to use a superficial temporal artery based flap, sir.
Yeah, composite flap, including the skin as well as the superficial temporalis fascia. What
And
my
we
point?
are
And this
using
will be rotated on this long pedicle towards the area of interest. Can you see? Now, a lot of people talk about the temporalis muscle. Number one, temporalis muscle has a vascularity coming from anteriorly, and it doesn't have that much of a long pedicle to rotate over it. Secondly, the bulk, the thickness. We don't want too thick a flap to impede the transmission through the magnet. Number three, it should be easily usable without any donor side morbidity. See this island flap, this area will be closed by primary closure. Once it is elevated And this can be transferred easily with such a long pedicle you can see. Can you see? Hello?
Yeah, yeah, very
Yes,
clear,
sir.
very
Yes,
clear.
yes.
Yeah,
This is
very
the
clear.
simplest
Very
of the
nicely. Yeah.
flap one can think of, including the skin. Otherwise, you know what people would earlier used to do, would rotate the temporoparietal fascia from anteriorly to cover the implant, and then rotate the advance the scalp from behind based on the occipital artery over here. That can work also very well, but then the attendant thickness of the scalp and the flap is too much, you know, which is undesirable. Number two, for surgeons who are working in this region should have a complete information of all the flaps in this region with their vascularity, because these flaps are important not only for the CI purpose but for other otology and lateral skull based procedures. So this temporoparietal flap for the people, everyone, this flap is based on the superficial temporal artery. As the name implies, I can palpate the artery here over the zygoma. This is superficial, and this flap is a thick flap, loose areolar tissue flap containing the vessel in the mass of the flap. It is just beneath the skin follicles. So first flap in the depth in this region is the superficial temporalis fascia. Is a huge flap in this temple region, huge temporoparietal region. This is temporoparietal fascia, which can be used for many purposes, including lining of the mastoid cavity for many of the skull base, lateral skull base defects, and coverage of the implant related problems. And microtia reconstruction, our friend Dr. Ashish has been using it. He has demonstrated a couple of times for the microtia, the cartilage coverage in difficult situations. Now, underneath this temporoparietal fascia, the next layer of fascia is the temporalis fascia. So, this temporoparietal fascia, the superficial one, is based on superficial temporal artery. Deep to this is the deep temporalis fascia, which is based on two vessels. One is the, the vessel on which the temporalis muscle is based, the deep temporal arteries anteriorly, and behind is one of the branch from the superficial temporal, that is middle temporal vessel. So that is a thin flap, temporalis fascia flap, deep temporalis fascia, which we use commonly for our tympanoplasty. And one can rotate a flap based on these vessels, a vascularized flap, which is known as a Hong Kong flap. But this is not a thick flap, a thin fascia flap, which is not as vascular as a flap as superficial temporal fascia, not thick as superficial temporal fascia. Deep to the temporalis fascia, the next layer is the temporalis muscle. Temporalis muscle is a huge muscle in this region, has an interesting vascularity, and after understanding the whole concept of vascularity, now more than 15 types of flaps have been designed from the temporalis muscle. Temporalis muscle flap can be used for various purposes, not only for uh, the the otology and the lateral skull base procedure, but for other defects of the eye, oral cavity, and the scalp defects. It can be used post cancer surgery. It's a versatile flap. So this temporalis muscle is a huge muscle in this region, which acquires its vascularity from its depth by means of deep temporal vessels. So this anterior to posterior, this entire temporalis muscle, as far as the vascularity is concerned, is divided into three segments. The anterior 25% or so segment is supplied from depth by the anterior deep temporal artery. Hello? Hello, Dinesh? Can you mute the mics?
Yes, we can see.
So the anterior 25% or so is supplied. Dinesh ji, hello?
Yes.
So this anterior part of the muscle is supplied from depth by the anterior deep temporal vessel, which enter the muscle from its deeper surface. Then these vessels form an arcade in the anterior 25% of the temporalis muscle, coming from deep depth of the muscle to the surface, forming the arterial arcades all the way, traversing the muscle depth, coming from the depth to the surface, and that is how this part of the muscle is supplied. And you can simply, if you want anteriorly to cover the orbital and the eyelid and many other defects in the oral cavity, you can simply take this partial muscle flap based on the anterior deep temporal vessels. Then the middle 40 to 50% of the muscle mass is supplied by the posterior deep temporal vessels. That is the major bulk of the muscle supplied by the posterior deep temporal vessels. Again, coming from the depth of the muscle, underneath the muscle, to traverse through the muscle mass to come on the surface and forming arterial arcades throughout the muscle. So the vascularity comes from the depth that we need to keep in mind to protect the vessels once you raise the muscle. This is the middle major part of the muscle supplied with the posterior deep temporal vessels. And posterior, one third or so, is supplied having a dual vascularity from the posterior deep temporal vessels as well as the middle temporal artery, which is a branch of superficial temporal artery. So this posterior one third of the temporalis muscle, which is commonly used to rotate and fill up the mastoid cavity defects and for other lateral skull base procedures, can be rotated, isolated, the posterior one third to cover such defects and to fill the cavity based on deep temporal vessel, as which is a branch of superficial temporal, and the posterior deep temporal arteries. So based on the concept of vascularity, these three segments of the muscles can be elevated as a dual segment, bipedal flap, triped flap. Many kinds of temporalis muscle flaps have been, devised after the initially Rambo discovered the temporalis muscle flap. And this has been a usual part of our otology and lateral skull base, as well as the head and neck cancer surgery practice. Yeah, for facial palsy, temporalis advancement flap, so many flaps have been discovered. Now, deep to the temporalis muscle, the last layer of, the flap, which can be used as a flap, which is very, very useful, which we have demonstrated a couple of times in our webinar, is the middle temporal base artery based pericranial flap, periosteal flap deep to the muscle. And that's a very, very useful thin flap to cover some important areas, like discussed with Ashesh many a times when he makes the extraorbital canal, to cover the canal with a thin, middle temporal artery based periosteal flap, which where he can use the split skin graft over it to line the extraorbital canal, to line the cochlear implant electrode arrays, to line the defects of the tegment tympani. For many regions, the thin flap, the periosteal flap, based on a vessel that is known as the middle temporal artery, arising from the superficial temporal artery at the level of the root of the upper part of the helix. Here, coming depth in the depth, and they run like two vessels, the artery and vein, like a the railway track appearance in the periosteum, right from the above the pinna to the level of the superior temporal line, and one can rotate this flap very simply to cover many of the defects. So this region is full of vascularized flap, and we need to understand the concept of vascularity to optimally utilize the proper tissue for the proper situation. And in this situation, we have our plastic surgeon sir has already marked this composite superficial temporal artery based flap. And any questions before we go ahead?
Yeah, Satish, just I want to ask you,
Yes, please.
what is the reason your plastic surgeon is not recommending that occipital artery or posterior auricular artery inferiorly based flap?
Yes, you can. Deepak, I've already mentioned.
Yes,
We
I
need two
missed that.
things.
Yes, yes, yes.
We need a dependable flap. Dependable means on vascularity. A thin flap, not a very thick flap. Reliable one. Away from the incision which was previously used, which may have damaged the vessel.
Okay.
And that is why the superficial temporal artery based flaps are the preferred one,
Okay.
which has been the virgin area from previous surgery. Remove. See this?
Okay.
as
Yes.
compared to the
So the
post-auricular flap, which may have damaged the vessel earlier. We never know. Number two, even if it's not damaged, we don't want a thick, the thick scalp from behind, which is relatively thicker than the thinner scalp anteriorly to cover the implant, which can impede the transmission through the magnet.
Okay.
So this
And
composite
occipital,
flap, see this, how
Deepak.
thin is the scalp over here? How thin the scalp is?
Yes, yes.
The scalp and the thickness of the superficial temporal artery is not more than the scalp over this region, and that is
And the
why this
occipital artery needs to be mobilized much more into the nuchal line.
yes,
It is far easier to use the superficial temporal artery. The
absolutely,
access is very, very good.
yes.
So it is
We
the first
want
choice. Even in low hairline, Deepak,
Yes,
you've seen
yes.
us. You use the
Okay.
superficial temporal artery.
we want a thin
Okay.
profile of the flap at the same time. Now see what we intend to do. First of all, I will open up this. My utmost precaution would be to save the
Implant.
implant. Will follow the area of infection and the biofilms, whatever.
Yes. You are going to change the position of the bed of the implant also?
Yes, definitely. See, this is one important thing what Deepak has, mentioned. We have two options. Either to bring in the new vascular flap to the same bed or to relocate the implant to a different bed, to a new vascular area. Here, we are going to do the both. I am going to relocate this implant after cleaning the bed. If I find the bed is too good, not warranting me to relocate to a different place, I would use it at the same place. But since the bed has been created in the past and the biofilm must have occupied that, it is always better to relocate to a adjacent area. Number one, and then bring in a new vascular flap. Now, relocating to a new area is a tricky job because you are not supposed to bring out the electrode array from the cochlea. You have to be very careful not to mobilize the electrode array from inside. Okay?
So here I would just like to add that the assistant should be very careful because I'm working in a medical college. So by mistake, the retractor the resident was holding came on the magnet, and we actually had the whole device pulled out. And we
Yes,
were
yes.
lucky that we could reinsert the same device. But this has happened with us once. Like,
Yeah, that can happen. That's why
so the
relocating the
assistant,
implant is a tricky job. You have to be very, very careful. And what Madam has mentioned is the real, concern.
the
See,
magnet got
my
stuck in the
goal,
instruments.
my goal is to debride all this, bad tissue and bring in the fresh tissue at the margin of the, dissection. Can you see this fresh tissue?
Yes.
So I will remove this bad tissue which is ischemic, infected. I am blessed with a great plastic surgeon with me. Whatever I resect, he will reconstruct. I know. That is what we have been following in our, oncology practice. Nowadays, no need to ask. Remove whatever you want to, they will reconstruct. Don't need to ask even.
Does he do face transplants
Can you
also?
see something? Can you see something? This jelly-like material? Anybody? Let me increase the magnet. Can you see this jelly-like
Yes,
material?
yes, yes,
Yeah,
yes.
this is the
This is
biofilm.
biofilms.
So also, I would like to add something here.
Okay.
Like here, the implant is very much
And
exposed,
yes,
but sometimes it is very little exposed. So what when I started, I used to place the dummy silicone thing over the expected site of the implant. I used to mark it with a pen so that we do not damage the implant lying below the skin. So
yes,
with a marker pen, we can mark out the area where the implant is expected.
yes, madam. See, this biofilms covering the prosthetic surface with lot of irregularity on the prosthetic surface invites the biofilms further. With now new implants coming up with antimicrobial coating, with more, the implant designs with less depressions on the implant surface are welcome to prevent this biofilm formation.
Yes, sir. Sir, Dr. Sanjeev from Delhi wants to know, can the same implant be used on the other side after removing it?
No, no, not really.
Yes.
Not really.
And sir, what about the use of cautery during this salvage procedure? Should we use in these
What?
re-infection cases? Dr. Ashok wants to know.
What to be used?
The bipolar cautery and all those things in
Yeah,
revision cases.
bipolar you can use once it is required, no issues. But in implant surgery, I always mention we always try to avoid the use of cautery. I would say minimize. See all these biofilms. See the biofilm on the prosthetic surface.
Yes, sir.
I have under high magnification to show that. See these biofilms. See this jelly-like material.
Yes.
This is biofilms. This is right in contact with the prosthetic implant surface. Can you see that? Silicon. See the irregularities on the surface of the implant inviting biofilms. Can you see this jelly-like material? This is biofilm. So I will free first of all from all around with a healthy skin and subcutaneous tissue margin. Then I will elevate the implant. Skin hook. Yes. See, this is healthy tissue. Can you make out?
Yes, sir. Yes.
Yes. The most important thing is the radical debridement to achieve the healthy margins. To remove all this non-viable ischemic tissue, infected area. Yes. And second is to keep the implant protected. You are not supposed to pull it out. Now, the most important thing for everybody, what is biofilm? See the bed. Hello?
Yes, sir. Yes.
Hello?
Yes, yes, we can see.
See this. This is
Yes, yes.
biofilm. Can you see this film?
Yes, yes.
This is all biofilm. Huge. What antibiotics you can expect to work
Okay, okay.
on this biofilm in the presence of implant? Impossible. Impossible to think of. There's no point in giving repeated antibiotics.
And so most of the time when we send this biofilm for culture sensitivity, it comes.
Yeah. We send for the histopathology. It doesn't turn out to be any more than a chronic inflammatory tissue. For the cultures, it doesn't reveal much with a lot of antibiotic coverage. And cultures are not the means of identifying the biofilm for that matter. You need the gene sequencing. Gene sequencing is the method to detect the variety of bacterial colonies. Then the other most sensitive methods is the fish hybridization method or the electron microscopy to detect the biofilms. Cultures are never the means to detect the biofilms. See the biofilms. See the huge, massive section. Once we remove this tissue, clean our implant with the anti-biofilm agents thoroughly, bring in the new vascularized tissue with better antibiotic penetration, we can hope for this to subside.
Dr.
See what I
Satish,
am ensuring.
it's like a chronic granuloma sort of thing. So we keep on
Pardon?
healthy surface, isn't that? It looks like a chronic granuloma,
Yes. Yes. Like,
and we have to clear it till we get a fresh margin with bleeding. Is that
yes,
okay?
exactly, sir. Exactly. This is the
Yeah.
principle of debridement, that you need to
Yes.
debride until you get a fresh margin with good vascularity.
Yes.
See this? I am taking some extra cuff of tissue to regain the vascularity at the margins. Can you see this?
Yes, sir. Yes.
Yes. Yes.
All this is problem. See this? All biofilms.
Good bleeding surface. That's
Yes.
yeah.
Yes. See this? अरे सर को mic दे. See, this was the suction. This was the implant bed.
Yeah. Is this implant working? It's okay.
Yes, yes. We got tested,
Okay, good.
and I hope Diksha from the Cochlear is online on Zoom. Has Diksha joined? Can somebody tell me? See, that is the mastoid cavity coming up. See this all unhealthy area. See all this unhealthy tissue.
Yeah.
Can you see the mastoid cavity inside coming up?
Yes, sir. Yes.
And looks good. See this, the cavity looks fine. Can you?
Yes, sir.
This all bed was so much engrossed with the biofilms which we have elevated. And
Yeah,
this biofilm
Satish.
is something which is most resistant to any antibiotic.
Satish,
Yes. Yes,
Satish,
Deepak.
actually, when we do the normal surgery, means even then the placement of electrodes in the mastoid bowel, we say the overhanging mastoid, and it should not, the electrode should not touch the musculoperiosteal layer. You must place like that it will not touch. So that in such revision cases, the risk of damaging the electrode will be less when we put it nicely in the mastoid bowl.
Yes. See, this is the unhealthy tissue, biofilms with tissue which I have removed. Can you see the biofilms again?
Yeah.
Yes, sir. Yes.
And this
And
is the
what is
healthy
your
tissue now all around. Had there
what
been
is your
tissue, had there been this tissue continuing along the, the cable into the mastoid, I would follow it. Definitely, I would always follow it to the level. We have seen many a time this tissue filling the biofilm, filling right into the mastoid cavity. In one of the patients, we have seen occupying the middle space as well.
Dr. Satish,
Yes.
can I add one thing? Like many of the post-op cases, you get a lot of granulation tissue. Once you remove those all, and there is a perfect bleeding surface, 9 out of 10 wound heals. So many of the cases of so-called biofilm, which we have
Yes.
already dissected out, it presents as a chronic inflammation only, or a
Yes,
granuloma.
yes, exactly, sir, exactly. We are
And
treating on the same line what you are talking. We are treating on the same line, removing the infected tissue,
yeah,
cleaning that area from all around, and bringing in a new vascularity to penetrate new antibiotics
Right.
to make it more effective. Now,
It
see
is
this.
extended a good debridement of the surface.
Yeah, now you see Pani Dana section. See the biofilms have almost been excised, you can say. Can you see the mastoid cavity?
Yes, sir.
Yes, yes.
Looks healthy. See the healthy tissue all around with no biofilms anywhere visible. Can you see?
Yes, yes.
Yes, sir. Yes.
See everywhere.
Yeah.
Now we will further clean up this area. And meantime, what I will treat this implant with? This implant surface with lot of irregularities on the surface with lot of depressions can still harbor microcolonies. Now I will dip this implant in certain solutions, and the number one amongst that. Can you see this tray?
Yeah, yeah.
This tray contains manuka honey.
Nice. Okay, sir.
This I am using honey with a concentration of 3 milligram per ml. You see my implant is submerged in manuka honey. Hello.
Yes, yes, sir.
Yes, yes.
I will keep it for some time in this, completely submerged in this. Then I will submerge this implant in a solution containing a mixture of hydrogen peroxide and betadine.
Okay.
And that is something important. Hydrogen peroxide working like a surfactant to remove the biofilms from the surface. And this manuka is deadly to the biofilms. Completely submerged in this, and we'll wash it thoroughly to remove all the biofilms, all possible, though we have macroscopically we have already removed. And this is to finally treat the implant with this and the surfactant solution. We earlier used to use, the Johnson and Johnson, baby shampoo as a surfactant, because this is a prosthetic surface where the biofilm colonies still may survive, escape from our cleaning, and we need to use some surfactant. Use as a surfactant to brush away the biofilm colonies from the prosthetic surface. Now we will drill away the bed of the implant thoroughly to remove the biofilms which may have persisted on the bony surface. Will make this bone absolutely healthy, clean. Then we'll make our well adjacent to this, little more anteriorly, a new surface, a new well for the implant, and then our sir will bring in this composite flap over it. That is going to be the whole plan. I hope you understood what we are aiming to.
Yes, sir.
Yes, yes.
Any comments? Any suggestions?
Dr. Satish, can I suggest something?
Yes, sir. Please.
Number one is the question: how long you keep in manuka honey the implant dip?
5 to 10 minutes.
Okay.
This question is very relevant. I tell you.
Yes.
Initially, this study from Professor Bardi was conducted in the Belfast University using a tea tree oil.
Yeah.
Professor Brady from Belfast University.
Yeah.
He used a tea tree oil as a component to kill MRSA biofilms. It works against the MRSA biofilms.
Yes.
He used different concentration for different period, and finally he found if he exposed the implant to the tea tree oil with a concentration of 5% for an hour or so, it completely kills the biofilms. And that's a very useful thing. But you never know always it is a staph aureus biofilms. That is the biggest question mark. The same was published by our own Dr. Shalabh Sharma from Delhi once, using the tea tree oil and make the patient biofilm free. So similarly, a lot of anti-biofilm agents have been used. So the duration of exposure to the anti-biofilm agents is a question mark, and your question is relevant that how long you will submerge or dip in the manuka honey for this. So what it has been discovered that a 10 minutes, 5 to 10 minutes exposure to a 3 milligram concentration of manuka honey is deadly to all biofilms, and this is what we are doing. More than that, we will rinse or implant, we'll submerge and rinse with the hydrogen peroxide betadine combination, which acts as a surfactant and antimicrobial agent as well. And then finally, place or implant in a new bed, covered with a newly rotated vascularized tissue, which can bring in effective antibiotics to the area of interest. This is what the plan. His keenness are there. Can we learn from him anything else he does, or anything out of his experience?
As I said, I have never used Manuka honey. So it's worth a try if you feel that it is going to be more useful in removing the biofilm than other agents that we've used in the past. So no experience with Manuka honey, but would definitely try it in the next case. Yeah.
Okay. Besides the biofilm agent, the entire philosophy, this works.
Yeah, you remove the biofilm, you recreate, you sort of drill away the bone over that
I am going to.
area.
Yes.
Yeah, and then create a new well, little more anteriorly,
Yes, sir.
and cover it with a flap, rotated vascularized flap, which the plastic surgeon does for us. Yeah.
One more point. Can I add, sir? Hello?
Yes, please, sir.
Basically, it involves number one, excellent debridement, which is very important. Secondly, creating a fresh bed, and thirdly, putting the flap. So, since so many things are involved, how much importance you can give to Manuka honey versus rest of the things you were doing?
Yeah, you cannot calculate. You're right.
Yeah.
But since this is a dreaded complication where you are putting in everything to save this implant,
Yes.
you can't, compromise on the basis of efficacy, whether it is working or not. Number one, you're right. Number two, there is no harm in using that. And since we have amazing results, we hope this is working well. So the principle of removing the biofilms and bringing in the new vascularity is the key principle to deal with any infection anywhere in the body.
Yes.
We are exercising here as well. Along with this Manuka honey,
Satish, can I ask you a
Actually,
question?
Satish, the point I wanted to make was, just because you are using Manuka honey, we should not be complacent on the other part of the treatment. That is the proper
no, not really,
debridement.
not really, for sure, sir.
Yes. So
Yeah,
the
Satish.
message should be, that is very important part.
Satish, one question, that before you started using Manuka honey, I'm sure you were doing a similar technique, but using some other agents.
Yes,
So
sir.
do you think that after you started using the Manuka honey, has your technique changed, or it's only the Manuka honey that's
The
changed?
results have improved.
The results have improved.
I never use Manuka honey as a beginning in the post-implant situation. I've been using this for a sinus infections,
Yes.
Yeah.
biofilms for the paranasal sinus.
No,
And
but the
for
rest
that-
of your steps remain the same.
yes.
Ah,
And
okay.
I've tried a lot of things for the sinus infection. Manuka honey was one of the last. I used in the beginning a lot of, Johnson and Johnson baby shampoo. But the issue was was quite irritating to the patient, so which forced us to stop using that. Then for the staph aureus biofilm, the biggest question, you never know whether it is staph or pseudomonas. But it is predominantly staph, so many a times After that, we started using other mupirocin solution and other things. So mupirocin was so difficult to acquire, because what mupirocin we use in clinical practice is the oil-based ointment,
Yes.
which cannot be dissolved in a water solution and cannot be rinsed thoroughly. So we contacted the manufacturer and acquired the dry powder of mupirocin. It was so difficult, and finally the manufacturer agreed us, but not less than a kg. On 1 kg of mupirocin cost 2.5 lakhs. So finally we acquired mupirocin and start all those patients mupirocin rinsing, and it worked like a magic. Particularly for the staph infection, it cleared the infection in few days like a magic. After going through the literature studies and the studies that it may allow the infection to settle in again once you stop rinsing. But once we thoroughly rinse the cavity with the mupirocin, we use the other measures to prevent biofilm formation, like we improve the immune status by giving vitamin D, by means of giving probiotics, by means of adding on clarithromycin. Macrolides are one of the agents which can help prevent the formation of biofilms. And all these patients, after this surgery also, I will follow with two drugs for few months. One is rifampicin and another is clarithromycin, at least for 3 to 6 months, to all these patients to prevent biofilm formation, because they work on the mechanism, on preventing the mechanism of quorum sensing, which is essential for the biofilm formation. So after the mupirocin rinsing, we started working on prevention of the biofilms, and that included the addition of the clarithromycin as well. And it helped us, keeping a patient disease free for a decent period of time and incidences. And that is how, on the way, we discovered silver nitrate spray. Silver nitrate has been traditionally been used for the dreaded infection, including pseudomonas for the wound infection, burn infection, and the nasal sprays are available. So we started using silver nitrate spray. Being little irritant, we stopped further using, but still I am using in some patients because it is so easy to use. And then finally heard about Manuka honey, and we went to the literature and finally acquired, proven by the Watson and Hill laboratories, and then it has become a standard of care for us so far. Now we don't need to look at what biofilm it is, which is otherwise very difficult as well, and you can use it irrespectively for any infection.
So Dr. Palaniappam wants to know the mechanism of action. I think you explained many times. Can you again explain how this honey works?
It is not the honey; it is the content, methyl glycol in it, which is deadly to the bacteria.
Okay.
So do you use steroids
See,
also?
see, my implant is still submerged in Manuka honey.
Yes, sir. Yes.
Time.
Where else we use this Manuka honey besides this? Miss, what are the other
Pardon?
indications? Because you know everything, Satish. That is the reason I am asking you.
Pardon, Deepak.
Where else we use this Manuka honey? I am
For any
asking you because
infections,
you. Okay.
this has been extensively used for the diabetic wounds.
Okay. Okay.
Any recalcitrant infection, you can use.
And I think you have explained in nasopharynx also you are using extensively when it is the
Yeah.
chronic inflammation.
Anywhere. I have been using in the sinus cavities.
Right.
Okay.
Even a single application works like a magic. Believe me. You can
So
try out.
in sinus cavity, how do you dilute it? Like how to apply it?
See, we fill in the wide bore suction in the syringe with a wide bore suction tip
Okay.
as a thick solution, and we can paint it wherever it is required.
Okay. Okay.
So have you tried this in skull base osteomyelitis type of thing?
At the end of the surgery, when we do debridement, I've been using it. We have been doing couple of, in our regular practice, a lot of malignant otitis externa with dead necrotic tissue. So everywhere when
Okay,
you are
okay.
dealing with a dreaded infection, you can add on this.
Sir, Dr. Gauri Belshage from Pune wants to know, ma'am, ki, sir, any experience with the rifampicin powder?
Yes, I've been using rifampicin. I told you, whenever you use fat for obliteration, we
Yes,
always,
yes.
dip in rifampicin. Use it. Always use it.
Dr.
Rifampicin
Satish,
here
when you are using,
in this particular setting, I'm going to use rifampicin as oral, you know, tablets along with the clarithromycin for few months.
And sir,
coming back to Manuka honey, Satish,
Yes, sir.
once you have done away with the debridement, before placing the flap and all that, will you like to give a thorough wash of the cavity with the Manuka honey dilute solution?
Yes, yes. I will thoroughly apply it.
Yeah. And near the electrodes, you just try to take out the granulation
I
tissue
will
or you
make
just leave it
a
as such?
paint of Manuka honey everywhere.
Okay.
See, I am removing this bad bone, which is supposed to be, you can presume to be an osteomyelitic bone.
Yeah.
The superficial bone until you get a good vascular, normal appearing bone. This is in the area of contact with the biofilms because this can invade the Haversian system of the bone as well. So thoroughly removing in that region, thoroughly in the region of the biofilm. This was our previous bed. You can see
So
previous
do
implant
you
bed.
do the rifampicin wash also in locally before closing?
Pardon?
Rifampicin solution, a wash with a rifampicin solution.
Not really. My wash is with the Manuka honey
Yes, sir.
and the hydrogen peroxide betadine combination. Rifampicin will use post-operatively as an oral agent.
Right, sir. And that
again,
is
many
for
people are asking.
3 to 6 months.
Rifampicin is a very effective anti-staphylococcal agent and also been used as an anti-biofilm agent, which I
Yes,
am going to use along with the macrolide clarithromycin.
Right.
And that works again very effective to prevent biofilm formation.
yes, sir. So again, Dr. Gauri, Dr. Palaniappa, many people want to know how you get it in India and the cost. Like from where
How?
you get it. Sir, how you get it, Manuka honey in Jaipur, from where you get it?
Yeah, from
Uh,
New Zealand. From New Zealand.
Dr.
Okay.
Satish,
Yes.
answering to that question, just now I saw in Amazon Manuka honey New Zealand.
Yes, just there I also see
It's
1800 to 5000 is coming between.
there are a couple of brands.
Yes, yes.
No, I tell you. Let me. It is in the
You
screen
know,
is front of me. It's couple of them are displayed. One Life Monofloral Manuka Honey UMF 5 Plus certified 250 is 1899 plus of course maybe shipping something.
yeah, see, these are a
There are
lot of
couple
Manuka
of brands.
honey brands. These are
Yeah,
not approved for medical use. I tell
Okay.
you.
yeah. So which one is to
Go
we should
and
go for
find
it?
out approved by Watson and Hill Laboratory.
Watson and Hill Laboratory. So that should be made clear. And what is the cost approximately?
This the last bottle I acquired was around 125 New Zealand dollars,
Do the
between
Amazon
15
in
to
India
20,000.
because okay, do the Amazon in India deliver it to
Pardon?
please? Does Amazon in India, if you want to buy through the link, like it is showing other Manuka honey, this Watson Lab does it
No, no,
supply
no, no,
that?
no. That's why we don't use that.
Okay. So this is very important point that just not any
Yes, ma'am.
So
Am I
nowadays you
right?
don't wrap it with a gauze piece
Yes,
that you were
yes, sir.
previously doing,
Dalila.
sir, after soaking the gauze in manuka honey.
Patli la.
That Satish Jain, sir.
Okay. Yes, yes, madam.
So I had seen you once wrapping it around with a gauze piece soaked in manuka honey. That we are not
Yeah, we
practicing.
will do. Once sir
Yeah.
is harvesting the flap, we'll do that.
Yes, sir. Okay.
पकड़ के रखना.
Sir, Dr. Mong Kheng from Yanong wants to know, do you remove the battery of the implant while using dithermy?
Not really. No, it's a betadine or hydrogen peroxide. Now I'm using the combination of betadine and hydrogen peroxide and leave it for some time until sir harvests the flap. See, the entire region is being disinfected using the povidone, iodine and hydrogen peroxide. ये रख थोड़ा. See that? And we'll keep it like this. इधर आ जा तू. इधर आ जा. We'll keep it like this for some time. My bed is, now disinfected. Once sir elevate this, I will create a new bed and position this implant into that. Okay? My new
Yes,
bed
yes.
will be, let me show you, adjacent to this previous one, little anteriorly. See the whole thing now again. My new bed will be here, little anteriorly. See, this is the
Any
ball electrode.
any region behind it, because you can put it towards the occipital region also, any region?
Now, I don't want to be farther from the flap,
Okay,
as close to the flap as possible.
okay, okay.
यहाँ बेड बनाना है, ठीक है? This is going to be the site of the new bed. Okay? Okay?
Yes, sir. Yes.
This is going to be. So let's wait. I can, meantime, make the bed also before sir starts cutting the template.
Sir, Dr. Sunil Shamdhani from SMS Jaipur. Hello.
Sir, yes.
Yeah, sir wants to know, by using all these anti-biofilm agent, is there any chance of their diffusion into the inner ear or damage to neuroepithelium?
Not really. It has been proven safe. Yeah, I know. The same concern we had once we started using it, but it has proven to be safe. We never encountered any problem like this before.
Okay.
But how it will go in the inner ear, na? How it will go?
It can. You can't stop it. A minimal diffusion to the inner ear, you can't stop it. And for post-implant scenario, you have already opened the avenues to the inner ear. So far, I am using the cutting burr. डालना, सक्शन नहीं चल रहा. So now my job will be over and will be taken over by sir. And this important to learn from him, this simple, which he has simplified, this flap.
Like Dr. Ashok from New Delhi is saying, can we make a bed posteriorly if we are using occipital flap, occipital arterial flap?
This is one of the options. I don't deny that.
Okay.
But we generally avoid that as it gives a more thickness of the scalp over the implant, which we don't want.
Okay.
Though vascularity point of wise, it's a very, very robust flap. No doubt about it. Doubt about it. Some patients where there is no possibility of using a superficial temporal artery base like previously used somewhere or something like that, that is another viable option, I would say. Diamond.
Okay.
Diamond. See, this
Just
is
like a query.
important to fix your implant. This is one of the reasons for the problem. Fix properly. Implant should not project over the skull margins to press on the skin. That constant pressure under the skin is one of the reasons. It gives rise to this problem. And then proper fixation. Still, I believe proline is not the matter which material which give problem. It is purely inert material. It is the cut ends of the suture projecting towards the undersurface of the skin are the real culprits. So, we'll show you. Always enroll the suture ends. पतला देना डायमंड. करके रखना देखो. नहीं. See, you're one of the assistant. Role is very important to hold the implant in position to prevent it coming out, pulling out of the cochlea, which channel medal mentioned is one of the important aspect. Whole thing can be ruined.
Actually, you are dipping in some solution. Otherwise, you can put two stay sutures and you can keep.
Yeah, so वो दे periosteo. चलो, सर इसको कर लो. Now some tie down holes. See the ball electrode. Implant migration is one which invite this problem. So the implant fixation is very, very important. See the tie down holes? Hello?
Yes, yes.
This has to go underneath the muscle, which is already there. Now the same holes, section करना है. बोलना पड़ता है.
Another assistant role, you can apply to stay sutures because you are dipping in some solution. That is the reason the assistant is required.
Yeah.
Otherwise, two stay sutures can keep the implant away from your field.
Now I don't want to take any chance of implant migration.
Yes, yes.
See my periosteum working as a guard. See, it's fine now. The opposite tie down holes. Now, a gauge piece wrapped in manuka honey. Give me. Soaked in manuka honey. Gauge piece. Now, finally, I leave my implant wrapped in manuka honey. Gauge piece. Until our sir does, the rest of the work. Now, our job is finally to fix the implant and sir will cover it. Meantime, we'll utilize this for again. पकड़ के रख, पकड़ के रख, खींच के रखना होता है, ठीक है? See, I am wrapping my implant completely in manuka honey. Can you see this?
Yes, sir.
Can you see this?
Yes, yes.
And then finally we'll fix once sir brings the flap. So this is the final scenario. Now we have the area free of biofilm, any sort of infection. We have a new bed nearby, little anterior, and we are waiting for the new tissue to come to cover it. Yes, tu pakad ke rakhna. Sir, please. You want external camera or microscope? External. So bring external camera, please. Anybody has any doubts or any suggestion, please come forward. For the benefit of everyone. External camera, please. लाओ इसको और इसको इधर लगाओ, इसको हटा ले माइक्रोस्कोप. सर एक मिनट माइक्रोस्कोप हटा रहा हूँ. टटवा बिल्कुल नहीं हिलना चाहिए. तो पकड़ के खींच रहा है थोड़ा. यस, टॉप लाइट एंड द एक्सटर्नल कैमरा. स्टैंड लाओ ना आपका. Just a minute, we are organizing the external camera. This vessel runs so close to the skin, under surface of the skin, that just deep to the hair follicles is the vessel. So you have to be very, very careful while raising the flaps, staying just underneath the hair follicles to get the entire thickness of the temporoparietal fascia along with its vessel. ऊंचा कर लो इसको, फुल ऊंचा करो. सुन, यहाँ स्टैंड आएगा. टटो तेरा हाथ, तू किसी चीज पे ध्यान मत दे. खिंचा खिंचा कह रहा हूँ. घुसा बस यहीं ध्यान दे. इधर आओ. इसको पहिए के नीचे से ले लेना. खिंच रहा. Yes. Huh? Yes. Say hello. Can you hear, sir? Hello. अरे कहाँ गया? सर का माइक ऑन है क्या? देखो देखो एक बार. हेलो उद्भव.
Yes, sir. Yes. You are audible.
Can you hear Pradeep, sir?
No, sir. No, we cannot hear Pradeep, sir.
Sir, say hello.
Hello.
Hello. Sir, your voice is not audible.
Hello. Hello. Now you can hear. Hello.
Yes, yes, sir. Yes, sir. Now we can hear.
Hello, I am Dr.
Hello.
Goyal. I am a plastic surgeon at SOS Medical College. Right. What? Just a minute. Huh? तू इधर ही ध्यान रख, तू इधर उधर मत देख. Okay. So first we have to identify. If you have a Doppler, you can identify the superficial temporal vessel. But we had identified just by palpation in front of the tragus. Mark the anterior branch. This, you can see the anterior branch.
Sir, actually we
Okay, wait.
cannot. Sir, we're not getting the picture.
Just a minute. Adjusting his camera.
Yes, yes. Now the picture is coming. Yeah.
Okay. So we had marked the anterior branch. Can you see that?
Yes, yes.
Okay. And we have the posterior branch over here. Just palpate the vessel and mark. Right. And whatever skin defect is there, that we have to mark, which is required for this particular defect, which Satish has created on the posterior aspect in the postauricular region. It is based on the posterior branch of the superficial temporal vessel. So this skin island which we are going to harvest along with the superficial temporal fascia flap, right? Can you see that the marker is not exactly working? Can you?
Yes, yes, sir, we can see.
Okay, just a minute, just. I think now it's clear. Yes, sir, very clear. Okay. Right, sir? Now I think it is visible. This much of the skin island which we are going to harvest along with the flaps. We'll start with the anterior incision. We had given an incision for the skin island. That's clear?
Yes. Is there any ratio between the length and width to prevent necrosis?
No, nothing, because the scalp is highly vascular and it's based on the we are harvesting along with the it's the axial pattern flaps basically.
Okay.
Right.
Okay.
It's the posterior branch, so that we can harvest quite comfortably whatever tissue we require on. Of course, it has to be on the superficial temporal fascia only. You can't go beyond that. Right. Then we have a incision, a sort of a lazy incision. No, just it's not, because the vessel is just in the subcutaneous, just below the hair follicles. The superficial temporal fascia is just below the hair follicles, so we have to dissect below the hair follicles. I'm wearing my glasses, so that is good enough for me. Right now, there's no need.
Hello, Udbhav, can you hear me?
Skin hook, please.
Hello? Hello, Udbhav?
Yes, yes.
Yes. So he is doing without microscope, you know?
Okay. Okay.
He's used to this. I've seen him doing sometime using, some other microvascular reconstruction using microscope and using, what do you call that?
Even not using loop?
Loops. He's not even using
Okay,
loops.
for microsurgery, we use loops.
Okay.
But I would prefer to use microscope myself.
Yes.
See, he's
कौन
so
सा?
precise. What he said is you just need to stay deep to the hair follicles to protect the vessel.
You can see the hair follicles, and there is a definite tissue plane just superficial to the superficial temporal fascia. You go along in the small fatty layer, you can say the subcutaneous fat is exposed along with the hair follicles, so that you have to follow that plane.
Which focal length loop is good for head and neck surgeries?
Yes, the you with the loops which are now available, the focal length is around 40 to 50 centimeter, at least
Deepak,
40 centimeters. So you can have a good focal length. It will give you a better working distance.
Deepak,
Okay.
this flap I
Yes.
have been using couple of times. I have used to reconstruct the skull base defect after the endoscopic surgery.
Okay.
In
Okay.
situations, I remember those patients post radiotherapy, no option of using Haddad flap already destroyed the vascularity.
Okay.
The pericranium flap earlier used, and we
Okay.
use this temporoparietal fascia flap, which we mobilize underneath the zygoma through the infratemporal fossa to cover the endoscopic defect. How versatile it can be. This couple of times we use for the lining the cavity after the lateral skull base defect or a huge mastoid cavity.
Okay.
This is having such a robust blood supply from the superficial temporal directly from its branch. Here he is using the parietal branch, and you can see the vessel.
Show you in a minute. You can see on the skin side the subcutaneous fat which is visible. There is no
Yes.
fascia. It's all on the
See,
floor.
that is the plane.
That's the plane you have to follow.
If you miss the plane or go little deeper, you'll end up damaging the vessel.
Yes. Yes.
And the deeper plane is going to be the deep temporalis fascia, which we all know we use for tympanoplasty.
Yes. We use
Good.
this term millimeters dissection. He is doing the dissection in millimeters,
Yes. And
micromillimeters.
yeah, and that too naked
Yes.
eye. See the moves is with his knife without
Yes.
damaging
Yes.
anything, using the knife in a
Yes.
tangential plane.
Yeah. Excellent.
Another thing to
Excellent.
learn from
Yes.
them is another thing to learn from him is the minimal use of cautery in not only this in other practice as well, other flaps as well, by means of using the dissection, using the
Plane.
scissors to stay in the right plane is the key.
Yes. Yes. So what can he give us the tips how he is maintaining this plane by seeing the hair follicles or
Yes,
just seeing the plane of the fat and the muscle?
the subcutaneous fat along with the hair follicles that you have to follow. And,
Okay.
you will be exposing the hair follicles, but not damaging the roots.
Yes.
You can see my knife is pointing at the plane,
That
Yes.
is
Yes.
the true plane.
and this is sort of a avascular plane. If you go deep, there will be a lot of bleeding, and
Yes.
because you will be
Yes.
damaging the main vessel, right? So you have to be superficial to that.
After using variety of flaps, we realized this is the best one, which is quite thin, which is required to cover the implant with a robust blood supply containing the complex tissue of skin as well as the fascia.
Yes. Yes.
So for us, this is the ideal flap now.
चलो आप जाओ उधर. Uh, yeah.
and your knife should be not vertical. You have to use it little horizontally, so that you won't be damaging the major vessel.
माझा mic on करा. Hello. Yes, Satish, hi.
Hi, Ashesh.
Hi, Satish.
Yes,
So in
sir.
PIP, Gayatri will start showing the sculpting. We have harvested the rib.
Oh, that's great.
Okay.
Great. Ashish,
Yeah.
Ashish, since you have been using
Yes, the
TP
TP
flap
flap.
quite
Yeah.
often.
Yes, I will start making comments now.
Yeah,
One of
please.
the important surgical trick is to do a hydro dissection with a 30 gauge needle. First of all, mark the vessel like he has marked. You see we get a handheld Doppler. It hardly costs 25 or 30,000 rupees, and you can mark it. Here I was to show it, but now it's too late. It is done pre-operatively, so you can mark the branches. We actually went through a long phase of doing a CT angio, and we still do the vascular mapping using the CT scan for the low hairline patients or the patients in whom we use Medpor as a material for ear reconstruction. So this is one, mapping the vessel preoperatively, mark them. Two is just a few millimeters, 2 or 3 millimeters beyond the lumen of the vessel. With a 30 gauge needle, I do hydrodissection with a saline. I either use plain xylocaine and saline, but never adrenaline, and create a hydrodissection plane there. Then what he is doing just now here, because he's an expert, you can keep getting, it's that much easier to find the plane there. It just starts to peel off like a banana peel or an orange. The person retracting is also supposed to put a little bit more pressure, and then the strokes of the knife. I got a harmonic. Satish, I bought a harmonic just for this, and now I really don't need that. I will use 90% of the time the 15 number scalpel. Sometimes there are perforating vessels which go in deep into the scalp, and they can bleed and mess up the field. Now here I'm seeing that his field is very good, but at that time I will simply convert for that small region to a monopolar, remaining in the same plane. This I think is very important.
Deep
That's
sir.
right. Yeah, I agreed with you, Ashish.
Is
The
Gayatri's
hydrodissection,
thing
you
visible?
can get a good
Yeah.
plane with hydrodissection.
Okay, okay, just show the deformity here. Satish will just show the deformity.
Yes.
Ashim is on the way. He should reach in the next 20 minutes.
Okay. And before that, Ashish,
yeah.
one question from Pradeep sir. Sir,
yeah.
If the status of the superficial temporal vessel is doubtful because of the previous surgery in that region,
yeah,
what would be your next choice?
Occipital artery. That's the best one. You have to go far beyond, and mobilizing it takes a little bit. I mean, because you do that many less of the occipital arteries. Not that it is difficult, but it's an equally robust flap.
See, Ashish, how simple it is now.
Yeah.
He has developed the island along with the skin.
Yes.
And
Yesterday when you told
depth
me, I was
is
not able
temporalis
to.
fascia. Depth is
Correct,
temporalis fascia.
Yeah.
It will simply elevate in the depth of temporalis fascia and rotate behind in the vicinity. See how close is the new well created.
Yes.
It is not far off. That's why we don't create the well behind like Deepak asked. It is better to keep anteriorly so that your flap rotation is much easier.
So,
there are a few surgical points about
Can you see the skin island?
Yes, sir.
All around, I had exposed the superficial temporal fascia, and this is the posterior branch of the superficial dome. Can you see that?
Super.
Can you see that posterior branch of the vessel?
Yes, sir. Yes.
Yeah?
Very clear, sir. Super.
Right. So this is the based on this, and I exposed the complete temporal fascia, and now we will divide the deep superficial temporal fascia.
Hi, Ashim. Welcome.
Reached?
Satish, Ashim is here now,
Oh.
so I'm on steroids. I can do my bone bridge.
Yeah. So, Ashish, a simple announcement.
Yeah.
For everyone, the next Sunday, 17th of January, is our webinar. And the theme is Steppies Carnival. We did a Steppies Carnival, 50 Steppies in 2 days in 2013. This would be a mini carnival
with, I would say, 15 cases or more of stapes surgery that day, starting 9 o'clock from 3 centers. One from Thane, Dr. Ashesh Bhumkar would be operating. Other, the Master Blaster Ashim Desai from Mumbai, and then one from Jaipur here. We are operating. So 3 centers, more than 15 cases with different tools, different equipment, different techniques, different pistons, all those things, laser, non-laser, every possible thing we'll try to include in the discussion and demonstration. So next Sunday, 9 o'clock, Stapes Carnival.
Can you see? I had raised the superficial temporal fascia.
Yes, sir. In the plane of deep fascia?
Yes, yes. From the depth. What is visible under that is the deep temporal fascia.
Yes. Can you show once, boss? Jara focus karna. Yes. See, he has elevated the island. Along with the vessel we have seen. And the deep plane is so obvious, that is temporalis fascia, we all know. See this, the vessel, the
Yes, sir.
pedicle, the superficial fascia along with the skin.
Somebody was asking about the length and the breadth. That's not applicable. This can actually be like a tennis racket. You
Yes.
can have a really, because there is
We,
an
we
artery.
have a named vessel. Now there is
Yes.
no, it is not a random flap.
Correct.
This is a named vessel. There is no question of calculating the depth and breadth.
But it has to be on the superficial temporal fascia.
Yes.
The territory of that vessel. You can't go beyond that.
It can occasionally cause you post-op edema because the venous flow takes time, or sometimes the lymphatics, and then first few weeks or 10 days there can be a small edema on the flap. In this scenario, not relevant, but when we use the flap to cover the framework, that's when the contours get obliterated. So, and one of the days, I think we will show the Bedford
Now you can see that the complete flap.
low hairline case. We had one actually, but unfortunately we had to do it.
Pass it under the skin, sir.
Yeah, I will. Can you see that now? Almost our dissection is complete.
Hi, buddy. Hi.
This is the skin island along with
Good.
the
I'm just going to make
Now the rest of the job is to fix the implant and suture this flap over it. That's it. Ashish, you can start whatever you want to.
Yeah.
You're planning.
Has he cut the flap? Yes. Okay.
Yes. He is through. He is through. So what you can do, you can start showing your planning. Our job is simple. We have to just fix the implant.
Yeah.
And see, he has tunneled the flap behind. See this flap behind?
Through the, correct. Yeah.
And now it will cover everything. So final job is just fixing the implant and suturing.
The flap has been transposed to the defect. And
See,
everything will be closed primarily.
what a flap with robust blood supply, with the fascia as well as the skin, not very thick, ideal for covering the implant. This is what we wanted to.
Has he undermined the donor side skin for primary closure? Not yet.
Yeah, he will.
Not yet, but
He will easily.
we can close it
Easily. Not a big defect.
Little bit of undermining.
So Ashish, you can start showing your planning. We'll keep in PIP.
Yeah. So this is we have marked here. Ye dikhao.
Yeah. Can the audio visual?
For 5 minutes, we'll show you the surgical planning and drawing, and then Gayatri will show the sculpting.
You want the camera right now?
Sorry?
You want the camera right now?
Yeah. If he's there on PIP here.
No, we can't see. So what I will do,
I can see
to expand your picture and we'll keep in PIP. So explain, people want to see from beginning.
Yeah. So I've just taken the skin incision and I'm waiting.
Please keep explaining, Ashish.
Yeah,
there's a lot of requests from people.
Picture is when I am on the screen.
You can watch us, suturing the flap, fixing the implant in PIP. Yes. What is going on, Ashish?
Can you see me?
Yes. Yes. What
Yeah.
exactly is going on?
Okay. Okay. So now, so the rib has been harvested. We'll show you this. The pende. The mirror image of the pinna of the opposite side has been marked here. So
What
this
are
is
these marking for, vessels or something else?
no. This is the superficial temporal artery. This is the vessel that we have marked. But this is where the new ear is going to come. This was the deformity. I've just taken an incision, and I'm going to start. Sorry, my light is coming in the way. What is better? This is better, or without the light is better?
If you use that OT light, roof light or headlight, upper
Okay,
light.
okay. This is better now.
Little dark.
Yes, yes,
Okay.
ऊपर का light लगा.
yes.
No, this is too bright.
Too bright.
This is
You can reduce the brightness of roof light, na? Yes.
Okay.
Yes.
This is the superficial temporal artery which we have marked, which is what our friend has dissected in your case. This is the area of the new ear that we are going to make. This has been marked depending on the mirror image of the opposite side. And in this particular case, of course, like all cases, we are going to remove the deformed cartilage, create a skin pocket here, the subacute pocket. In this case, in addition, we have done some imaging, and probably you will do it at a later point to explain. We have chosen this. This is the dummy of the bone bridge. So the bone bridge, the way we made, this is a well-developed, reasonably well-developed mastoid, but completely sclerosed, and there are no ossicles in the CT scan. Therefore, we have chosen, and this is the approximate area, the axis in which we plan to keep the bone bridge. So from the same incision, I'll be able to access the mastoid, and I shall be able to undermine and create that skin pocket. This is the plan. When I open up, I think the axis may change a little bit here and there. Okay. Now I think I'll be removing the deformed cartilage and creating a skin pocket in the next, hopefully 15-20 minutes.
If the deformed pinna is not there, then you have to put in a normal case the bone bridge.
Yes.
Then what should be your planning?
Then it is in fact even simpler, because you just need to make that 8 millimeter well in the mastoid. So in the post-oral area, here my challenge is, through the same incision, I want to access the mastoid and the pocket behind.
Okay.
That's where it needed a bit of planning.
Yes.
So we are going to use the older model, the 601 of the bone bridge, because the 602, which is a much slender one, is not yet available. I think we've been told tips after it will be made available to us from April in India. That's a much slimmer one. And the well that you'll need to make in the mastoid is hardly 4 millimeters. Here it is 8 millimeters. It is a better engineering design.
Bhumkar sir?
Yeah. Today, because
any
we are
dimensions
not,
of the
we are going to be
mastoid?
putting an implant. I have, like Satish mentioned, we have not used adrenaline. So we are, in this case, otherwise at the incision site, I use xylocaine with adrenaline. So therefore, we are having a little bit more oozing than at other times. Sorry, Chanel, you were saying something?
Sir, are there any dimensions of the mastoid that we should be observing before we plan a bone bridge?
Yeah, I mean, it should, there are dimensions of the bone bridge, so it should fit there. That's for sure.
And what is the difference between bone bridge and Baha tract?
So bone bridge is a active this thing. So the FMT, the one which goes into the mastoid, that's the one which actually vibrates. Whereas in Baha, the vibrations are on the external device. So this is a direct internal, the vibrations are better. So the quality of hearing with a bone bridge is supposed to be far superior than with a Baha. But Baha, of course, surgically is that much easier. But the Baha attract, Ashim is here. Ashim could probably give Ashim a mic.
Yes, yes, please.
How are you? देख के वहाँ गिरेगा तो वो वही पढ़ाएगा. हाँ?
Hello.
Hello, hello,
Deepak,
good morning,
can you
Ashish
hear
sir.
Yes,
Ashim?
yes, yes.
Hi Deepak, how are you?
I'm good, sir. How are you? Nice to hear from you.
My pleasure to be here to watch the master in action as always.
Yes.
No, to answer your question, there are two bahas. One is the direct and the other one is the attract. The
Yes.
problem with the attract is that the vibrations are occurring in the external device, right? Which is
Yes.
transmitted by magnet. And therefore, it's literally hearing a muffled sound. It's like a speaker through a carpet, you know.
Okay.
So the quality of sound with the attract is not so good as compared to the direct coupling with the abutment. So
Okay.
But the abutment comes with a different set of
yeah,
challenges.
the abutment comes with a different pain because often you get the skin infection, skin breakdown around it, so on and so forth, at the junction of the skin and the titanium abutment. They've tried to cover it up with hydroxyapatite and so on and so forth, but at the end of the day, you do tend to get problems. So here you have the best of both worlds. You have nothing coming through the skin, and you also have the quality of a directly coupled abutment coupled device, you know.
No, one more is there, sir. Bone breach. I am not talking about the abutment the implant. I am talking both are subcutaneous. The bone breach and
Attract, that's the
No,
attract.
that's what I said. The attract. The attract is subcutaneous, but the vibrations are occurring outside.
Okay.
You understand? So, and it is because the vibrations are occurring outside, it is the vibrations are conducted through the skin and soft tissue up to the bone, and therefore the quality is that much inferior.
Is there somebody from the Bone Bridge? Is there Mr. Singh or somebody on Zoom? Do you see anybody from Medal?
They say they use the word active and passive bone
Passive,
conduction.
correct.
Yes, yes.
There's nobody here for the attack. They don't come.
Hello.
Oh,
So this is Mithun.
This is Medal.
बोलो
Medal.
मिथुन. अरे मिथुन
Mithun
आपकी
from
आवाज
Medal,
सुनना
sir.
चाह रहे थे बोल. Yes.
Sir, as sir explained, the bone bridge is being a active device. So its FMT is inside. It is inside the skin. So the conduction of the sound is much better, and the quality will be better in comparison to us. FMT, which is a vibrator which is kept outside the skin and transmit the sound through magnetic coupling and all that. So that is the advantage of bone bridge, and additionally it gives you a better threshold in comparison to the other devices.
Yeah, but
That is,
today,
these are the
even for our own microshare, we thought I just injected saline. That's
Okay.
a big mistake.
Okay.
Is a very specific material, suture material that you're using to fix the rim on the cartilage.
It's a 5-0 steel wire by Braun.
These are double-ended needle steel wires. They're made by B. Brown.
Yes, sir.
One can use Prolene, no problem, but this just makes it more precise and easy. So the key is that the sculpture that you make, the skin should be a rock-solid sculpture. It should not be flimsy. Otherwise, the healing forces of the skin, they can distort the framework. So having a rock-solid framework is mandatory.
Okay.
Sometimes we'll need up to 30 or odd wires per framework, or 30 or odd sutures.
Yeah,
So
so there should be
Gayatri,
no movement between the two parts that are being connected.
sorry?
So the two parts that we are fixing should not move.
Yes, they should not move at all. Over a period of time, there's fibrosis, but until the fibrosis occurs, the skin can distort. And in spite of this, sometimes we have the helix which sort of can get a little bit twisted.
Right.
So it's that powerful, the right angle.
Sir, Dr. Bhumkar, sir.
Yeah, Pooja,
Sir.
hi.
Hi, sir. Good morning.
Morning, hi.
Sir, Dr. Gitanshu Dahuja from Ludhiana has a question for you.
Yeah.
So he's asking if it's possible to do a single stage bilateral microtia surgery
Second
along with
stage.
a bone bridge.
Yes. So the second stage,
So the first
bilateral,
stage,
is asking the same stage or bilateral?
the single stage bilateral.
Single stage bilateral.
Yes, sir.
Yeah, we can do a second stage. Along with the second stage, we can do a bone bridge. No problem. In
Thank
fact, we do now for the earlier ones where we were not doing the atresia repair. We are doing the hearing improvement surgery anyway in all second stage. So we
Right.
are mobilizing the ossicles. Okay. Sorry, there will be not too much commentary. We are not like Satish that we have so much to tell.
No, sir, I think what we're
So you
seeing right
please
now
ask
is
questions and we will answer. uh, the sculpting, the beautiful part of the thing. Please watch. It's got typically four parts. There is a base plate which comes from the synchondrosis of cartilage 6 and 7. Then the eighth rib usually is 7 to 10 centimeters long, and that forms the helix. The entire helix is in one piece as much as possible, because then you get the right curve and the right height. And then the antihelix, the tragus and the antitragus, they come from the pieces that are sort of left behind. And in every case at our center, we do a CT scan of the rib, and that helps us to plan one, which side to harvest, right or the left, because whichever rib is more suitable for the framework that we have in mind, that is the side we choose. And the second is we can precisely plan beforehand from which rib, which part is going to come. So that becomes a very easy pre-op planning. And the helix, the anti-helix, the tragus and the antitragus has certain peculiarities of sculpting requirements. These are more in the three-dimensional plane, and there is a high point and a low point of each of these structures. Black.
So then for getting the right size of the cartilage, we need to have a chest circumference of at least 56 centimeters.
60 centimeters, beta.
60 centimeters.
60. So that way you can harvest adequate cartilage without causing any chest deformity. So age is not such an important criteria as much as the chest circumference. Up to sometimes, like in this case, we have to make the entire framework. So it is important to wait till 60. If sometimes they have the tragus, anti-tragus present, then you can compromise, and at 58 you can do it. But 58 centimeters. But anything below that, just because the child is 7 years or 9 years of age, but if the chest circumference is not yet 60 or more, it's not a good idea to do the rib reconstruction.
So the key here is that there's a lot of pressure from the parents. Sometimes the
Yes,
idea is to resist
table
that
khal.
pressure
Yeah.
and wait.
Hello, Hitesh. Hi. You see the TP flap that you all just saw in Satish's case. There are many times when I think when we do cholesteatoma surgery, can we make use of that flap, because it is really easy to harvest, and I did go through a small curve of using that flap to either vascularize the canal wall that we rebuild,
In fact,
or
it becomes a wonderful flap to use
Hmm.
to line the cavity. Because you see, one of the things that the plastic surgeons always recommend is that when you when you want skin to grow, the skin has to grow on a vascularized bed. Now, what happens is that when we try and allow the skin to epithelialize within the
microscopic
basement
picture लगाओ.
cavity, there will be forces of fibrosis, forces of granulation, and forces of epithelialization. And that is why we end up with uneven cavity.
Microscopic picture. बड़ा कर दो इसको.
So what?
Ashish.
Yeah.
Hi, Mike. Ashish.
Yeah, Satish.
Can I show for a minute?
Yes, of course.
Can you increase? Can you increase this? ये वाला बड़ा कर दो. Yeah. Are you getting the picture?
Yes, yes.
See, I want to show a couple of things. Number one, the flap. See this. What a flap. See the bleeding flap. Can you see?
Yes. Very vascular, active bleeding.
Active bleeding from the flap.
Wonderful.
See this?
Yeah.
See the vessel. See the flap vessel.
You are blessed to have Dr. Pradeep Goyal with you.
Yes. Now this implant has been fixed. This is the ball electrode. This is going to go under the muscle. And this flap is going to cover like this simply. And we'll suture it like all around. See like this?
Yes.
Simplest. See what an amazing. See the primary closure of the previous area, the donor area.
Yes.
Absolute bleeding vascular flap will cover this, and this will give a good closure. And on the other end, see the implant array.
It's totally clean.
Yeah, I want to show you something. See, what we were emphasizing, or one of the assistant was holding the implant all the time so that we don't pull it out of the cochlea. See the mastoid cavity?
Very clean.
See the implant going, and
Yeah.
see how it is inside, covered in mucosa. Can you see?
Healthy mucosa.
This is healthy mucosa. See all the way, this is array embedded in the healthy mucosa going to the cochlea.
Yeah.
Fine.
Perfect.
So now the implant has been fixed. It is totally healthy area with a vascular flap coming over it. And now we are going to suture it. Ajay.
Satish, show the burial of the proline. That's very important because the edges should not stick out.
Yeah, that's the important point, boss. See what we do.
Yeah.
This proline ends should be inverted. So see, these projected ends coming under the skin can create problems. So what you need to do is invert them medially. इसको ball electrode दूर करो. नहीं, दूर कर, अंदर कर. Yes. This proline should be inverted. Give me a little bit of the. Oh, मत करो उसको. That is ball electrode. Leave it.
Wash the hydro.
Would you like to replace the ball electrode in a slightly different position?
Yeah, we have to just push it underneath the muscle. Want to.
Fine, they're fine.
Leave it like this. इसको दबा ले. And this proline should be inverted underneath the implant.
Right.
Hmm? Hmm.
Give me some suggestion. Okay.
Helena, before dissection, एक 5 मिनट आधी xylocaine, plain
I will
xylocaine.
push it with some surgicel
Yeah,
in
areas
the
plain xylocaine.
tie down hole. Can you see
Where
this?
Yeah,
monitor.
yeah. It's a very
So
important
that
point.
it no longer projects over. And this will get fibrose. Chuna.
On occasion, I've used a drop of bone cement, Satish.
One more suggestion. Yes, section. Yes. Because this proline should not be projecting out.
Perfect.
This is one of the regions to erode the skin from below. See now?
Wonderful.
It will no more, projecting. Will not be. And now, this skin flap will cover everything. Suture.
Outstanding. Outstanding.
And in PIP, we'll show you the suture. Let Ashish go on and see what a great skin flap with tension-free suturing over it.
Super.
So this is the whole principle. Use of anti-biofilm agent, complete debridement, getting new vascularity, now followed with good antibiotics and biofilm preventing agents. Ashish, you can
Dr.
continue now.
Satish,
Yeah.
Dr. Satish,
इसको
can I
PIP
Now
में
we
करो.
have finished the skin pocket, and now we are ready for the bone bridge drilling. So I will now go
Satish,
to the
amazing flap, amazing surgery, amazing, and we expect that this would be a 100% salvage of the implant.
Thank you, boss. Hope so.
Dr. Satish, just can I make a point?
Yes, please. Sir.
This flap, basically from the donor side, has invaginated and you have brought it below the skin. So there
Yes.
is no second surgery
No?
required to cut the donor side and redo it, like in the nasolabial or other local flaps you do. Am I correct or I have understood correct?
Can you repeat, sir?
to say there are
The
5 skins,
donor skin has been come to this area with a
Yes.
subcutaneous
No,
tunnel.
no, yeah.
Yes,
And
sir.
the donor area is completely stitched. This
only
area
with
is completely stitched. So
Yes.
there is, from above, there is no connection
now
between the
actually now
donor
even I
and this
got the,
area. So probably we don't need to remove the,
size of the
cut
frame
those
also.
invaginated things.
Also right. Earlier
Like
I
in
showed
nasolabial
how
flap, we
size
do
of the frame,
require.
whereas with that millimeter here
Yes,
and
sir. Yes, sir.
Am I
there's
right?
our picture.
But the skin is sutured margin to margin.
Yes.
Yeah.
And the graft we have
Yeah.
brought is through a canal creating.
Santosh de mala.
You can convert any
How to
such
different
flap
of
into
microscope.
such island flap. That is the advantage of island flap.
Right. Yeah.
Yes.
That's the
Sir,
point.
what the flap you are talking about, nasolabial flap,
From here,
Yeah.
we use it quite
But we have
often
to
after
make
the submucous
right here,
fibrosis
here.
resection.
Yeah.
This is where
And
we
you
have
can
to
also
pass it
convert
from
that
under
flap
the-
into an island flap based on the artery pedicle.
Yes.
In the same way,
Yes.
in one of our upcoming webinars, if you want, we can show you the submucous fibrosis resection with a nasolabial flap placement.
Yeah,
And
sure.
that
It
flap
will be
again is like an island flap
okay.
based on a long pedicle of facial artery branch,
Mhm.
angular branch, same like this island flap.
थोड़ा सा
Because most of the time, Dr. Satish, we are used to raise the flap and invaginate
Till today it's
inside
been
the cheek
because
mucosa.
I'm
And
worried
after,
about
say, couple of months, you have to
access.
separate and cut it.
Rather than stretch, now I decided few millimeters. So the
You
match
can do single stage, sir.
Yeah,
That is the
that we
beauty
will
of
love
island
to see
flaps.
in some of
That's
the
the beauty of
forthcoming
island
seminars.
flaps.
Yeah, sure. That's good. Thank you.
Deepak Dalmia is also doing so many flap surgeries nowadays.
Yeah.
Deepak, you are.
And see, in this flap, there is no challenge. You have to stay in the right plane and identify and protect the vessel, and then take this island flap and rotate it easily. It is not
Actually, our
difficult flap.
vascular surgeons has taught us so well that now we are doing it ourselves and with good results.
Yeah,
Hats off to our plastic surgeons and vascular surgeons. They taught us so well.
yeah. And I am
Thanks, sir.
indebted to Pradeep Goyal sir for
Pradeep Goyal,
all
sir,
this.
thank you very much for teaching us.
Yes, yes. Satish, actually, we have seen this flap. I have only two slides having 6 pictures of occipital artery flap in a case of
Yes,
protruded implant. If you
yes.
Share
allow
it,
me
yeah.
to share my screen, I can show what
Share,
is.
share, share. It will be good for
Okay,
people.
okay.
And sir, in this, the raising of the flap is much smaller area than what we do with the occipital flap. You have to
Yeah,
raise.
the reason with the occipital is you need to mobilize almost the complete ipsilateral scalp of the posterior region. And second is the flap is too thick. That is the only thing which limits us using that. Vascularity wise, no issue. Occipital artery has a robust blood supply, no issue at all. But the advantage this superficial temporal artery based island flap is you get a composite flap under skin, that too reasonably thin to cover the implant, and the simplicity by means of which you can raise this.
Yes, it, yeah.
And I would say the versatility of this flap. If you have a more skin defect, you can use a little bigger island. If you place the implant little farther, you can take the flap little more further because it has a long pedicle. The beauty of the superficial temporal artery based flap is a long pedicle.
Deepak, you're showing some picture. What is that? What is this?
Yeah, Deepak, quickly show before the Ashish shows
Yes,
something
yes,
quickly. Yes.
yes. In a minute, I will show just to give the idea because we are discussing such an important topic. This is just a protruded implant, and we have planned like this. This is the ear, and we have planned. This is the vessel coming.
Okay.
I have given this incision along the protruded area, exposed this area, keeping the vessels in mind: the occipital artery, posterior auricular artery, and the branch of the superficial temporal artery. And now we expose this is the biofilm, and I have made a different well and put this implant here, and just we close this like this. And the sad part is after you can see nicely that it is closed nicely, but the implant again protruded like this. And then we kept here just to show this, we kept this here, the piece of cartilage also, just to cover this area of this speech receiver stimulator in the sitting. And this is again we close. Just I want to share this. Thank you.
Super. Great, Deepak.
So
Okay.
So we are at the final stage of closure. We'll show you the final picture once it is done very soon.
No.
Dr. Satish,
See, why I've called you here is now if I fucking land up with any emissary vein or this bleed, a sigmoid, that's the only.
Bhumkar was here online.
Oh.
Dr. Satish Jain, sir.
No, I have just.
Hello?
Hello, sir.
Yes, please.
Sir, Dr. Amit Kishore, sir, from Delhi.
Yes.
Complimenting you on the flap, as well as he's making a suggestion that he has stopped using proline a long time ago.
I know. Proline has been a big question mark thing. But see, I tell you, I big respect for sir. Regards to him, his question is valid. It is not the proline which is responsible as a material. Proline is a monofilament inert material. like any other material. It is the proline cut ends coming into contact with the under surface of the skin and eroding it, which is responsible for the ongoing infection and exposure of the implant. It is not per se the proline as a material which is responsible. It is the cut ends, how you use the finally the proline. That's why I had shown that how we invert the proline so effectively using Surgicel to invert it underneath the implant towards the tie down hole and fix it with the Surgicel finally to invite fibrosis over it and fix it so it doesn't come anyway in future close to the skin. Is it the proline which is coming close to the skin, finally eroding it and exposing and inviting infection? Not as a material, but the way we use it is the thing which is responsible.
Right, sir. So, sir is suggesting can Ethibond and Vicryl, like he uses, would be a great option according to you.
Vicryl itself can cause problem. Believe me, Vicryl is more responsible.
For arterial case, if you do, this
Yes.
is what you have
For
to.
that, a monocryl is a better alternative.
And just drill here.
Vicryl is not a monofilament.
Okay, sir.
So monofilament, monocryl is much better than vicryl, I would say in that context. We use monocryl.
Just elevate it, you start see how much anterior here.
Have you ever considered
Starts
a
to seem
patient
like
for
the
a
posterior
second
canal wall.
revision, like if this works?
Can you repeat? Can you speak
याला
louder, madam?
याला बाजूला करायचं आहे मला.
Like we hope that this survives, but in case the revision.
Hello?
does not
Just a minute,
survive-
madam. Just a minute.
Yeah. And you start seeing this, no, the spina Henle region. And now we just go, put the retractor in the, now you don't keep the retractor attached to the skin. You attach it to the soft tissue. That.
Yes, madam.
Sir, I was just asking that suppose we have done a revision and for some unfortunate reason, the patient again comes with a extrusion or exposure of the implant. Would you consider it for another revision or do you want to
That is
expand at
a
that time?
difficult situation, I tell you. Like after this procedure,
Yes, sir.
with full, after this, we'll follow with the antibiotics and anti-biofilm forming agents, which I
Right.
said. Initially, I would use vancomycin for this patient, assuming this is a staph aureus biofilm,
Right.
along with some types of intravenous vancomycin, followed by at least 3 to 6 months of rifampicin and clarithromycin.
Right, sir.
Still after this entire procedure, having done everything, the patient develop infection again, then I'll have to think twice to do before doing anything, and probably we will explant.
And is there any way where we can find out a hypersensitivity to the silicon or something like? Is it? Are
You
we?
can't.
Can we do
It has been held responsible
Yes, sir.
sometimes, but nobody knows. There's no way. And first of all, the casings have been changed by the implant companies nowadays. More biofilm protective implant casings and implant designs are available now. So that has been already going on by companies.
Right, sir.
But directly, we never know. The silicone casing can be held responsible because biofilm forming is a different mechanism than a hypersensitivity.
Yes, sir. Because even
This
doing
was
the
pure biofilm. This was pure infection,
Hmm.
not a hypersensitivity. You can
because even when you do a total and differential count, you don't get a eosinophilia. Like if we go for some allergic.
I have not seen any silicone reaction so far.
Right,
And
sir.
let me show. Viru?
Dr. Satish,
Yes, sir.
staying with the proline, I just wanted to make few comments. Like I was the first to use proline in mid-80s for hernia repair. That time I was in general surgery. The problem with proline used to be two. Number one is the knots are loose, so you have to give multiple knots. Number one. Number two, the ends are to be invaginated well. Otherwise, say for hernia repair, it comes out of the skin and it forms a granuloma. So you very correctly said invagination of the ends are very important. At the same time, while putting knots, you have to give couple of them in both directions so that it is interlocking stitch and it never loosens up. So proline is
Satish,
an excellent material. I agree.
Satish,
Hello.
can we hear comments of Dr. Ashesh Bhumkar for this bone bridge? How
Yeah,
what landmarks he's
yeah, he's
yeah.
coming to Deepak.
Yes,
In continuation to what the issue raised by Dr. Amit Kishore, who is
yes,
himself is a very renowned cochlear implant surgeon,
yes.
international fame.
Yes.
So this concern of using proline has made the surgeon use some alternative techniques, like
Yes.
avoiding the use of threads
Bravo.
to fix the implant. A lot of
Yes.
people using periosteal, gutter technique, periosteal coverage technique,
Yes.
and some different, material to fix the implant provided by the company rather than proline.
Cutting
Yes.
there.
All those things are alternatives to the proline. But
You have to
believe
keep
me,
some bone here
see
and
now
there
the
for it
final picture.
to fit.
Can you see the
Excellent.
final picture?
Excellent.
This is
Excellent,
the
great.
primary closure, which is going to be underneath the scalp,
Yeah.
and this
Yes.
is the tension-free coverage of the implant with a vascular flap, and see the thickness of the skin matching the surrounding skin. And we have
Yes.
seen the implant which was
Who
undisturbed
is
going to
here?
the cochlea.
Yes.
We
Ganpati. Yeah,
we
Ganpati. Hi.
put the implant to a new
There is
area
Sachin Desai, the
anterior to
master.
the previous one, thoroughly rinsed with the anti-biofilm agent. Entire
Yes.
dead tissue, avascular, ischemic tissue,
The
infected
section
tissue
वरती 8
completely
millimeter
debrided.
mark केला का?
The
Yes.
new island flap and the complete coverage and the closure. This is all about this case. Thank
Yes.
you very much.
Great,
Excellent.
great.
Satish,
And big thanks to Pradeep sir for this case. He has been big help. He has been in the forefront of teaching and training and has trained hundreds of plastic surgeons in this region. He's professor in the prestigious medical college and has been doing a lot of courses over there. Thank you, sir, once again for teaching all this. Thank you, everyone.
hello Satish.
Thank you. Now we are back with Ashish's case. Ashish, can you hear us?
Yeah, we can hear you. Can you hear me?
Here? Yeah.
So just one more comment that I wanted to make for the revision is that yes, you can do a hypersensitivity patch test. And in fact, I may even think of recommending it in those cases in which potential infection has developed, What is your opinion on that? The people don't know what is a patch test. You explain. हे माझं हे बंद आहे का? Can you see the well Dr. Bhumkar is doing?
Dr. Ashesh, can you please tell us the landmarks, how you decided where to make this well and this, that?
So yeah, that was actually honestly CT guided. And in this particular case, for the bone bridge, honestly, you just have to drill into the mastoid. You just have to make sure. My challenge is a little different when I'm doing it along with, as a bone bridge, as a surgery is quite, I think, simple and standard. When I'm combining it with my microtia, there are 2-3 things. In the primary surgery, I don't want any compromise to the skin vascularity. I don't want the implant to touch the framework at all. Otherwise, it will be miserable. And second, it has to be beyond the edge of the new ear that I make. So the marking becomes, preoperative markings become very important. And third and the
How
most
you
important
decided
is when
means
I do the elevation surgery, second stage, I want to make sure, because that's when the flap tends to be compromised. So nowadays in second stage, we started using the TP flap as a routine for every case. There are the 8 millimeters are there.
But how you decide
So-
how far from the spine of Henley this well should be? Means and where
really no spine of Henley that is actually there. It's a congenital ear. So this my TM joint is this is a TM joint. The only landmark I have is the TM joint anteriorly. I don't want to go any anterior to that. Other than that, the here I'm trying to define the middle fossa, the dural plate, and posteriorly will be of course.
But Ashish, since it's bone conduction, does
Yeah.
it really matter to the millimeter where you are?
Not at all.
Exactly.
It doesn't matter at all. You just have to make sure that the FMT fits into this. There are goal there. The FMT fits into it, and really the trick, and I think we've been speaking to Mithun about this, the medal guy. It's really just the screws. Apply the trick is in how the sound gets transmitted through the screws. So the well, in fact, they told me you can make an even deeper well. So I'm asking in.
suppose while drilling, if you enter in the mastoid, then
Yeah, you can. I have made my own acrylic things for me to be guided. So you open, but
we are just asking. We just want to know what we just want to know what will happen if we enter in the. Nothing will happen.
नहीं चलेगा. Thickness का problem नहीं.
Okay, no issues.
I want the diameter first.
Okay.
So,
Yeah.
so Dr. Ashmita Patel from Nairobi has a question.
So it's a much bigger. I was going more by judgment, so I need a much bigger well, but I decided to keep it narrow and then okay. Yeah.
So Dr. Ashmita Patel from Nairobi has a question for you.
Sorry, I can't hear you. Can we increase the Pooja's voice here?
Sir, am I audible now?
Yes, you are.
Yes, sir. So Dr. Ashmita Patel from Nairobi has a question for you.
Yeah.
So she wants to know if you test the implant after the surgery on the table.
Sorry, I didn't catch it.
So if you will test the implant after the surgery.
Mithun, can you answer, please? Mithun?
It is not required because it's not. There is no neural response telemetry or any such thing that is required for this.
Okay, sir. Thank you, sir.
I believe only the magnet thing one has to check. याला बाजूला कर.
Is there any issues of means scalp thickness in this case also? Issues of
No.
Not at all, because towards the mastoid you have adequate thickness for that, right? For the FMT to fit in.
No, like the Baha, they have that 7 millimeter thickness. For the bone bridge, there is none. Mithun? Who's your Ganpati? Huh. The skin's thickness, does it matter in a bone bridge? Yeah, please.
Yes, bone bridge, the bone thickness matters.
Not the bone thickness, the skin thickness.
Skin thickness, it should be less than 7 mm.
Yeah.
In cochlear implant, we usually say it is less than 6 mm. In bone bridge, it is less than 7 mm that we recommend.
That is for the magnet, efficacy of the magnet.
Can we increase the power of the magnet also, like in CI we can do that change in the power of magnet? Can we do here also?
Yes, sir, we can do that.
Okay.
Deepak, the issue here is not just to increase the power of the magnet, because sometimes, there is, if the magnet is too strong, there is a skin breakdown issue and soreness and so on and so forth. So if you find that the skin is very thick, it's better to trim down the skin a little bit,
Okay.
Rather than keep increasing the size of the magnet, it's generally what I have found as far as Bahas are concerned.
You are right. Even for the CI
so
also the same thing. CI
create a
also
sort
the
of analogy for this procedure.
yes, yes.
There is the sigmoid sinuses come here. Gold there. So now we are pretty much restricted by the anatomy.
What is the size of the well that you require? What is the size of the well you require approximately?
2 centimeters. The
2 by 2.
The diameter is 2 centimeters.
And the depth?
The depth for this one is 8 millimeters. For the new model that they'll come out is going to be 4 millimeters. So if it was a new one, we would be.
So what would you do in an extraordinarily contracted mastoid?
That is a challenge. So because it is 4 millimeters.
Yeah, that's no issue.
That I think we'll be able to manage just like the Baha screws.
Yeah.
Bipolar, please. Santosh, bipolar. कुठे आहे कुठे आहे? See the 8 millimeter the है कुठे आहे? I have a suction with a mark on 8 millimeters for the. एक minute.
Ashish, do you dip your framework in rifampicin also?
No.
What wrong can you do?
We've been doing it in betadine. That also, I think, if we remember. De Mara, dummy.
Open it.
Okay. I don't know what happens to this bleeding later. Diamond, the diamond. पानी नको टाकू. ते 8 millimeter suction दे. इथे जरा जेल फोम टाकून देऊ. Where is the 8 millimeter? Mark. Mark कुठे? Where is the 8 millimeter mark? इथे. अच्छा दे दो size दे दो. जरा can you show me right angle के? सॉफ्ट टिश्यूला जरा रिट्रॅक्ट करायला माझा हे याला बाजूला करायचं, राईट अँगल घेऊन. हा. So I need to झाडा section दे. Actually, तिथे जेल फॉर्म दे. We need to increase it quite a bit.
Yeah.
My visual judgment was far too short. जरा आतमध्ये जेल फॉर्म दे. I'll make sure the blood doesn't come in the way of cotton ball देगा.
JRH MD listened to all senior doctors, but our MD is confined to Dr. Mangla, Dr. Mate, and few doctors. Otherwise, she did not care and listen problems of us. ग्रुप में डालते रहते. वो फैक्ट है. फैक्ट तो यही है, मगर वो बस यही
दो लोग तो उनके उसकी भी वो दो आंखों के तारे हैं. वो किसी का मर्डर भी कर देंगे तो बनेंगे नहीं तुमने कर दिया. कुछ भी बोल लो. वो पता नहीं वंदना ने तो क्या लगाया.
सुषमा, मला हे बोन चांगलं दिसत नाहीये. मला रिट्रॅक्शन मध्ये
पूरा एक वो बना के. उसके बाद क्या हुआ गॉड ऑफ
दे थोडी एलिवेट. दिस इज हाउ आई वांट इट. जरा एक मिनिट देख और
ये जैसा कुत्ते जैसे लड़की दिखती सबके सामने.
I have to keep some good bone for the screw. So ये वरती घे. पेरियोस्टियम मध्ये बेटा रिट्रॅक्टर लावू का? This is not deep. Okay. Kids. Okay. Perfect. Okay. Now give me that sizer again, just for me to get a. मला पट्टी कसं हे कडून 8 मिलीमीटरचं थिकनेस दे. Cut it at 8 millimeters or 9 millimeters. Just a little bit more.
Is it necessary for it to be a tight fit?
No, not in the well.
Okay.
This is 8 millimeters. So from this is a 8 millimeter. So the depth is more than enough here.
Yeah.
So in fact, it is a little bit more. Suction, please. Occur. Yeah. So at this depth from this outer cortex, now I just need to get the diameter right. I think we are okay because the sigmoid is just about getting escaped. Yeah. 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 So now we will go watch.
2 centimeter by 8 centimeter, 0.8 centimeter.
Cut, cutting. They've all learned from the cochlear implant. The patients are willing to pay. There are boneless chop. I wanted to keep it around the screws segment.
Why would you want that?
Just in case the screw is little, I would like to fill in the, after the screw is fitted, no?
Oh.
I would just like to put little bone dust around it. Just for more osteogenesis, nothing else.
Is there also self-tapping screws like the Baha screw?
Yes.
Like the Baha abutment?
Yeah. This being an anomalous mastoid, I cannot take any chances. I have to be very, very careful. Although the CT has been done, but still
You have to err on the side of caution.
Caution, yeah. Cannot, because I'm just concerned about that emissary coming suddenly and screwing up the hole. Hmm? Hey.
So Dr. Sanjeev from Delhi has a question for you.
Yeah.
So he'd like to know if the sigmoid sinus is too forward.
Yeah, it can be up to 50% or more, or a little bit around 50% can be compressed with the FMT.
Right, sir. So,
It does not matter.
If you do not get the desired depth of the well that you're creating, what would you like to do?
No, you can compress on the sigmoid sinus. That's what I'm saying.
Okay, sir.
You can compress. You can compress a little bit also on the dura and try and fit. I think there's enough studies made which says it doesn't matter.
Okay,
It is similar to the cochlear implant. Sometimes you have to make a little squeezed oasis and then the dura is compressed in a very, very thin skull in a child. Same story, I think.
Yeah.
Thank you, sir.
Give me that sizer. It's bloody bigger than what you think, na? The size I have a issue.
Almost there.
Yeah. This thickness is how much?
The thickness is 0.8.
No, this is it?
Sir, no, sir.
No.
It's a sizer.
Ah.
To measure it, we have something else.
Yeah.
The next one is.
Yeah. They have to. Sir, okay. Anyway, give me the gold now. Mutha gold de ekdam. I think we are okay with the diameter. The last fine tuning I'll do. But, here? I'll straighten it up. Yes, you're saying.
You can see that the fast cutting diamond burr is a very, very useful weapon in your armamentarium.
थोडं कमी टाक. सिग्मॉइड दिसत नाही मला. नाही. वो दिखाओ लोगों को. Are they seeing the framework?
No, so we're looking at the drilling right now.
You
Now
can.
the sculpting is over. We'll try to put you on PIP so that you can see the sculpture. The work of art produced by the master.
Yes, sir. Thank you, sir.
Let's get the sizer again. The gel from the. Cotton ball. This sizer. Now give me 8 here. 8 measurement or 8. This is going to come in the way. Ah, there. Okay. But माझा पण दे 8 वाला. This will get pressed. See, Pooja, what you're asking, the sigmoid is going to come in the way.
Yes, sir.
We will have to press it, at least in the upper part.
Yes, sir.
Gold, please. So I'm just skeletonizing it. The barik the gold. See, this is right up to here. Very, very superficial. Huh? No. Just, yeah. So I don't need to go there. This is all I need to here. Hmm. Hmm. Suddenly, this 8 millimeter is seeming like a big one.
Yeah, that's the problem with these congenital ears.
Hmm. Give me now whatever is your good sizes, like wash karal de. Garam wala hai de. drill this now. नीट बघून सांगा दोघात. I had bought it to take it and leave it in Kazakh. They wash. Yeah. Cotton ball. It is a bipolar. Bipolar है. They. So give your sizes, sir. You finished? Has the triggers banla? Bagu? But you made from the other one? Let me see. Okay, nice. Hmm. This will go. क्या है? Good. एक मिनट से some reading. देखा? This is how many millimeters? This should fit now. But now I want to see whether because now the screw will right angle नहीं कर. See the screw I'll have to upload dummy there. नीट समजून घ्या तर कुठे मला हे करायचं. हे असं जाईल. हा स्क्रू आता इथे जाईल आणि हा इथे जाईल. कशा झालं? या इथे मला एक्सपोजर लागेल इथे. Yeah, no, but now the depth I have to check ना that 8 millimeter ते कसं check करू? How to?
If all the 4 lengths going, when you put in this one, if all the 4 lengths going, no need of any length and it is 8 mm. There are 4 lengths inside it.
There are four
lines.
4 lines. Okay.
If it completely goes in, it means that no lift is required. If it is uneven, you can use different type of clips on either side of the screw. Hello. I do.
So there is a lot that will need to be done. So this sigmoid is really coming in the way.
In that side, if it is lifting up, you can use one of the lifts on that.
And now the problem is, oh God. There's a bit of an issue that has happened. Now I am forced to do it here. I will. One of the mistake I did was I should not have. I should have drilled more anteriorly and kept this. No, but the screw will not fit. No, because the screw. No, but no, there's no way now to. Because if I do it like this, the device. It can. I got a 90-degree cotton ball there. I will make sure the
You can see in a continental asteroid, there's that much more challenges because of the contracted asteroid, the high sigmoid.
no, and yeah, and and then you think that Baha is so much simpler. You don't need to do all this.
Each has its own advantage and disadvantage. So the way forward is to decompress the sigmoid. Correct?
Yeah.
Yeah. Now see, when you are decompressing the sigmoid, what Ashesh is doing is he is drilling in the direction of the structure he wishes to expose. This is for the juniors.
Hmm. Yeah, please tell.
That side we can use lift.
On this side.
On that.
Yeah.
Use what? Lift.
Lift.
Screw can be lifted. Oh, keep it up. It underneath the.
Is that is okay? Yeah. Okay. I want to see now where to place the screws. You have the dummy of that thing. If I here that it. भैया 8 मिलीमीटर हो गया इधर.
All four have to go inside.
ऐसे दे रहा. This either. Now, Ganpati, how do you decide 3 millimeter the uplift?
Sir, this is based on the lines.
Yeah.
Put it in. If it is by seeing that from which side, how many lines are coming out,
Yeah, sure.
you can use so many lifts.
I understand.
There are 2 lines looking up. That means 2 mm lift.
So
After we remove the sizer, the sizer should be in position.
When you put in the sizer.
there are too many coming up.
Yeah, we need to go deeper.
This is Sir,
When you open this, and put this in, and then put the stick in, it will be more.
Ashim, do you mind washing up? Because I'll need your help. Yeah. जरा एक मिनट wash कर. No, I mean. This should be at an angle. You head on.
Hello. Hello.
Yes, sir.
Yeah,
Oh,
just Ashesh.
yeah, Deepak, hi.
Yeah, can we just decompress it, or I can shrink it by using the bipolar
Yeah,
over there?
yeah, I'm planning to do that. That is precisely what I'm planning to do. I'm just trying to mobilize it from all around.
Yes, yes.
1 minute, yeah. So I mean, way deeper where? No, here's the Dura now. Yeah. See those vessels?
No, deeper than that. This.
Oh. Ah. Okay, but let me.
You see what's happening is that you're going here. This is the magic shell. You have to cut it. It's a lovely. See, if you look at it, this is still The edge of the defect is at number 2. So if we take this down a little bit here.
Okay, okay. I'll take it to the maximum. Maybe we'll do it. Yeah. Okay, so we are grossly inadequate in the depth. Ashim has just washed up. Let me over mobilize the sigmoid.
You are exposing the pre-sigmoid dura.
Yes. And now that should be enough. Now this I have to be the same thing. Maybe I go right up to the dura now. Motor there. So we'll do the same thing. We will bipolar.
This is the sinodural angle region.
Not yet. Drill that. Yeah. मोटा दिला ना? क्या किती साईजचा आहे बस?
This was a 5.
5, no? So we are probably 8 then. This is 5. Yeah, this is the dura will get. The bone is bipolar there.
This is good now.
Now going in.
This is now much better.
But now that is not the better. What the problem is, the screws are on the. See in the device, the screws cannot be hanging in the bridge, no?
Yeah.
Huh? No.
No.
It has to be flat. So now, Bhagode,
That is to measure the where the screws is. It can be rotated 90 degree either way.
एक मिनट जरा periosteum दे दो. एक मिनट, I'm just seeing whether how much the sigmoid, because we need to be more at the sinodural angle. Yeah. Okay. Okay. एक मिनट. Yeah.
This is coming out well. You see here? And if you go down here.
Unfortunately I can't see. Leave.
One second.
Forceps दे जरा.
Yeah, stout forceps.
मेरे इसमें रखो, तेरे को दूं क्या, व्हाट्सएप कर दूं, तेरे को व्हाट्सएप कर देता हूँ। हाँ तो तेरे को व्हाट्सएप करता हूँ, क्या होता है तू उसको खोल, तेरे को सिखाता हूँ उससे कैसे व्हाट्सएप होएगा। वो तो तेरे कोई तीनों पेपर दे दिए थे, तू उसको खोल, मैं बताऊँ
वो भी ले लूं।
और उसको भी स्कैन करके भेज, उससे अच्छा दिखता है। ये क्यों लेके आई?
ये खत्म हो गई ना।
ऑनलाइन ही सस्ते मिलते हैं, और वो भी तू मेरे को दे देती तो मैं।
वो जो सब मैं लेके आई ना, मस्जिद बंदर से लेके
और इतना मेरे को लग रहा है तू वैसे ज्यादा टेंस हो जाती है, इसलिए कुछ नहीं, एक लेटर मिल गया।
नहीं, मेरे को क्या आपका सपोर्ट सबसे ज्यादा अच्छा लगता है। फिर आपका मेरे ऊपर करने लगे तो मुझे ऐसा लगा रहे, मतलब अब मैं क्या करूँ। अच्छा आप मुझे एक चीज बता दो कि मेरा कहाँ फॉल्ट है। मैं लेट गई इसके लिए मैं मना नहीं कर रही हूँ, और मैं लेट ऐसा तो नहीं कि कहीं घूमते फिरते जाती हूँ। आप खुद देखते हो कि मैं 2 राउंड
मैं उसको कह ही नहीं रहा हूँ, मैं तो ये कह रहा हूँ, और तेरे को मैंने हॉस्पिटल में तो यही कहा कि कोई बात नहीं है, टेंशन नहीं है।
अरे नहीं बोला, बहुत अच्छे से बोला, पर घर आके उसको नहीं दिया, वो इन्वॉल्व है, अभी अपन क्या कर सकते हैं।
नहीं
अभी
तो
भी
मैं
मैडम
उसको भी यही बोल, अभी भी मैं तो यही कह रहा हूँ कि अगर सपोज तेरे को दे भी दिया, तेरे पैसे भी कट गए, तो कोई अपनी किस्मत थोड़ी, तो छोड़ो ना, खत्म बात उसको।
मैं तो आपको देखा कि आपने मेरे को कभी
मेरे को तो यही लगता है कि इतना क्या, अभी उसको खत्म करो, उसके कारण अगर वो लेटर दे दिया, जवाब दे दिया, काट लो जो काटना है, खत्म बात।
काय को करता हम भी निकाल के देंगे ना ओवर टाइम। अभी शांति से एक बार रिप्लाई कर दे, ऐसा नहीं है। इसको क्या करना है मेरे को मेरे मोबाइल में बताना सिखाओगे।
तेरे इसमें स्कैनर डाल रखा है तूने?
मुझे नहीं पता।
Hello. Hello, sir.
Yeah.
Sir, Dr. Mohammad Sharif Alam from Gaya would like you to just help him with the anatomical orientation once.
Yeah. Yeah, we will. We are just next 5 or 10 minutes. We have to just get our this screw thing right.
Yes, sir.
To the best precision. But there's not much. This is the superior. We had the dura there and the sigmoid there. This is anteriorly is the TM joint. This patient is a completely contracted, completely no ossicles, nothing. It's just a.
It is very much in the
Huh?
It is very much in there. The screw may not go.
Okay, here.
Yeah.
Now it's okay.
The other one, sir.
This is fine. This is fine. That is why, yeah.
You'll have to go back up. Yes.
1 minute. Huh? This is not angled handpiece.
No, it's not.
This is his.
No, you
This
give
is my.
angled system.
And sir, this is used to not drill more than 3.5 mm depth, and the diameter is 1.5 mm.
Oh.
Rotate it.
No, but no. They have to mark it. This won't go in.
It will. It will. See.
It'll go.
Yeah. You have to move back. Your microscope out. Out. There.
You sure?
Yes, 100%. That's it. You made your mark. Let's see. And now
It's right on that fucking edge. No, that's not right, Ashim.
Okay.
No, this one is not right. It broke.
It's broken.
Here. That's the issue. We have over drilled there. Take minute. We need to breathe this thing. A right angle. Okay. Now what we need to do? See, here we have enough.
Yeah.
So let's fix this anterior point first, wherever it goes, and then we will. Yeah. See, supposing here, this is where give that thing, so it can come like this. Give me that thing. Yeah, 1 minute. Forceps दे माझ्या हातात. 1 minute. This is not going in.
Any greater depth.
Here also more it needs to be. It's not fitting, man.
See, I tell you what. No, if you rotate it here, see what. If you rotate it here, you got enough bone here.
But it's not. So then it's going to come out. The whole FMT is going to come out.
No, that we can drill more inside.
Can you use lift also for that? Can you use a lift for that?
Which one? No, bone has to be properly strong. If you use lift or not also, the bone has to be, the screw place has to be.
No, the bone is strong, but can we use a lift 1 millimeter or 2 millimeters?
See, if we do this,
how's that?
This is okay. उधर का देखो.
इधर अच्छा है देखो.
उधर अच्छा है. Then this is better, I guess. But this is.
That doesn't matter. We'll push it down somehow.
No, because this is way above the cortical bone. See, more than half of it is above.
Are we soft here?
No, yeah, we're totally soft. This bone is also mobile. This is not fitting. Maybe we can't go ahead. We leave it.
Here? One thing can be done. If you're sure one screw is staying properly, it can be done. Our literature says 2 screws are given for the safety purpose rather than 1 screw.
Are you sure?
Yes, sir.
So? Then one screw is definitely fitting.
Here also is fitting. See
this, huh?
See this. At this level, it will fit.
Is it? I can't see it.
You see?
No, it's on the edge.
Is it? Yes, it is. I cannot see. The only way is this. Now it's not on the edge.
We
See,
just go vertical light law.
What's the light now?
Just go. So there's no need to do that, no. So
Grab it.
ये इतना ऊपर नहीं आ सकता है ना. It has to pretty sink in. There is no. You want to sit and see if you want to drill the Dura more. Just see. Sit. Bus. Sort. He'll see if he can create more space. Just देखना in the safety.
You can always not do this procedure.
Yeah. If it's not fitting, because that was a good question somebody asked. What are the criteria of the mastoid? The diamond is this for us to make sure that beyond this we can't. That nahi hai. We were that 602 would have been good. 601 now that 4 millimeters are coming in the way. Had it been 601, we would have 602. We would have been. सुभाष चैलेंज क्या आ गया ना अपने को सीटी स्कैन में ये मैस्टोइड का साइज समझ देना चाहिए था इसके ऊपर वो जो 2 सेंटीमीटर का जो ये है ना वो स्कैन के ऊपर ही करके देखना कि वेदर या वी शुड उसका फोटो लेके जरा स्क्रीन पे दिखाओ ना हाउ द मैस्टोइड इज वो सिटी नहीं तो उधर कैमरा लेके उधर जाके खाली हाँ सिटी स्कैन पे है उधर खाली तुम दिखाओ उसको कि नॉर्मल और वो जो कॉन्ट्रैक्टेड है ना to think of the screws, huh? Depth is
superficial at all.
The depth is
in the depth.
Yeah.
See, I'm not going at all superficial. Now, you do something.
It is better without the microscope. This, the microscope unnecessarily takes time. निकालो वरचा लाइट ला हे दे मला right angle. Yeah, you sit on top of that. You'll get a good projection to start with. There you go. No, actually, yeah, the point is right. The screw is going to butt against the framework. No, it will be below the screw. The screw will fall flat. Yes. Screw is flat. At all like the Baha, the screw is totally flat. How's this now? Put this back. Give me another right angle. Section.
What's this? देखिए यहाँ पे. See, now it's really flat. See, it's touching. Bro.
Here it is touching. Here it is.
Yeah,
Is it
now
touching?
you got space. Now give me a hole.
Hole. Without E karo.
No microscope. Just want to see from top.
It's going. Yeah,
Do you mind?
no, not at all. Please go ahead. Yeah.
Same.
Okay.
Actually. Yeah. Really good. No, it can't drill. No, I'm not going to drill. I'm just going to see. I know, I can't. I'm just here. It's exactly on the edge. But it should be okay. Now what? Now coil.
Now there we have to get that pocket. So this gel foam टाकून दे ना. Oh, bleeding को एक कर डालो. Because I'm worried about what my hematoma for my microshia.
Centralize the picture.
So now, sorry, yeah, the outside camera can show.
Give me that one. Give me that one.
No, more. No, it will be.
Give me the size. It will go. Watch.
Please centralize the picture.
Okay.
Get the size of this.
Please centralize if possible.
Yeah. See, our challenge, my mic is on.
Yes.
My challenge here is because I have to work through the incision of my microshia repair. And at the same time, not cause damage. So there is a little bit of okay.
Constraint
Cool.
of incision
Okay,
exposure.
cool. Yeah.
Okay.
Yeah. So now get.
What angle it bends by fitting the other one.
Give me that.
But that once we fit it in, we will do. It's more.
Pre-bend is better. Otherwise, also it can be.
Sizer.
Screw
वाला अभी drill किया.
This one.
It doesn't really matter. वो तो ऊपर नीचे होते जाएगा.
See, inside it should go, sir. The coil. It is bending, you can see that.
Okay, so what is the issue?
Coil has to go much more up.
Further up.
Further.
Up meaning superiorly.
Oh, that we can increase elevation, no? Take it. Tell you still. Okay. That should be.
Dr. Ashesh.
Yeah.
Hi, good morning. The excellent dissection. Now I was watching you. Only thing I wanted to know, in this case also, did you use expanders to get a more of skin volume as in your previous cases?
No. The expanded skin for microtia is not the most preferred thing. The skin tends to contract back. One is it has a capsule, and two is then later on post-operatively, the cartilage framework starts to get deformed. So expanded skin is not a good. If at all, in burns cases, indirect expansion has been advised, but I haven't done any of those.
No, in last case you said if the area to put the implant is less, you use expanders so that you get a better skin coverage.
So 1 minute, sir. What did I say?
You need some more skin. So prior to surgery, you inject something so that you get a better skin. skin coverage of the prosthesis, the
No,
reformed
no, no,
pinna.
no, 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 no. That was the eye inject for the plane.
Okay,
No, not for the skin. Skin
not for the
expansion takes a
yeah,
long time, 50 days minimum, because the skin has a memory.
yeah,
So that
yeah.
that memory has to break. But it really doesn't break. The fibers tend to contract over a period of time.
Hmm.
So direct expansion is not advisable. Only in very difficult cases, trauma where there's too much scar. like that.
Post burn and scar cases, there you probably can have.
नहीं लगा
Yeah. Okay, so
वो
nice.
उधर जेल फोम लेके hemostasis करना. I don't want hematoma. No, no, but yeah. Hmm. Nothing. Okay. So it's my around. Okay. Okay. चलो okay. So now the implant बाहर से दिख रहा है? हाँ. Okay. Okay. Go ahead. I had the big idea of flattening it. Yeah. Good. Good. Okay. पूरा दूसरा लाइन.
Yes. See, oh, beautiful.
वो टॉर्क रेंच किधर है
Sir?
स्टेरिलाइजेशन के लिए
Yeah.
Not very well.
I think we fix one. Then, if need be, mobilize the periosteal.
Look at it, boss.
Perfect.
Look at
This
it.
well which you made
Okay,
is
lovely. Hello, screw it up.
intentionally you made this bigger.
I think it's
This
all right.
well which you made intentionally you made it bigger.
What?
This well size little bit larger. This is we have
No,
to
little
make it
bit.
or
Yeah.
it is
No, in this case, it need not be precise. It is the screws which have to fit.
okay.
So if the cavity is deeper, if it is wider, it doesn't really matter. The mastoid drilling.
Okay. Okay. The only risk is that the screw that the sometimes the screw will not get
Yes.
the enough
Yes, it should not.
space.
Correct. The bone. Correct. That's right. So you're right. It should have been more precise in terms of the diameter.
No, I am just asking.
No,
I am
but
going
you're
to
right.
do
It's the
this.
correct observation or point. The fenestra size is bigger than the.
उसको निकालिए सर उसके अंदर
अरे आप ग्लोव्स पहन के आ जाओ यार. हाँ तो करो ना, निकाल के दो ना.
Now,
take that screw out.
Take that screw out.
with my hands? Normally, they don't allow you to touch with the hands.
You can hold these screws with these forceps. Usually they say na the titanium screws you don't hold with
Exactly
this
that.
that.
I said exactly that.
The simpler the surgery, the more complex they make it look like. It's okay. You use your experience
Yes,
and
yes.
Where
But
is
the dental surgeons or titanium plates when we do this or facial fractures we are holding at the
Let us enjoy the screwing now, if you don't mind. Let's get these
Yes,
damn
yes.
screws right, because it's not like a piston that you handle.
Yes.
Dental people have special forceps for that.
Uh-huh.
Push it up.
We don't yet. I'm hoping this year to gather a vast experience in this bone bridge. So we are also in that. Screwdriver, please. और ये screwdriver किधर है यार? ये वाला
हाँ सर
तो पहले तो सादा वाला दो ना.
Take the top wrench out, yeah.
Hmm?
The top wrench has to
No,
go. This has to go out first.
no, later on, yeah.
That's a last.
Yeah, that's in the end. वो दिखा है क्या स्कैन?
It's not going in, right?
Is it in the hole, sir? If it is in the hole, it will go.
It should be in the hole, my friend.
Oops.
Self tapping.
And there's a light net there. गया?
Yes. अबे पूरा टाइट मत कीजिए सर, दूसरा भी डाल दीजिए.
हाँ. Because the movement, the axis change if need be. Yeah.
Let's see here first. No.
Suction. Suction कुठे?
Can I make another hole? It seems to be a little bit off. I'll make another hole with the drill.
Sir, if you make another hole, will it not be a wider hole?
No. They're a separate place.
It's in a separate place. Okay. Just a little bit. No, it's not good enough.
This is just to hold the screw.
Yes, it's the entry point for the screw to. Should we use that whatever they call the lift? Yeah.
Can we put a lift here or not required?
I'm not able to see.
Come on
will
this
have
side.
to
No? Come on this side.
Is it okay if the device?
Flat or is it like
No, it's a little up.
Then you have to use lift.
Oops, I got delifted. 2 mm.
So because of the angle of the mastoid, there's a little gap there. So we are filling in a titanium spacer. They call it the lift. So it comes in 1, 2, 3, 4 millimeters, no?
You can have up to 4 millimeters.
Yes, sir, we can have.
So we should have done 4 millimeters inside and 4 millimeters.
No, but then your
The whole would have been, assembly would have been up.
Your the cartilage would have come.
Cartilage, yeah. So we'll have to have a radiological protocol for selection of Baha versus bone bridge, I guess.
2 seems to be too much. Huh?
Shall I take 1 mm, sir?
I think so. Yes.
This is what is this?
This is the lift.
Can
you give me one?
Underneath the screw.
Yeah, but this I. Like this?
Yes, like that.
Like this? Under this?
Yes.
I think we are too much. Too much.
Give me 1 mm.
Give me one. Take it out. Take it out. See, one, sir. Only 1 mm.
Well, like he said, even if one screw is fitted, it's okay.
Let's try for 2.
Yeah.
And what happens if one screw falls down? Do you have extra screws?
There are in the tray also there is screws.
If you are not able to fix screws,
Rescue
you
screw.
can apply tie down hole.
Okay, give me 1 millimeter.
Actually, ऐसा ठोक डाला तो भी चले.
Huh?
ऐसा ठोक डाला तो भी चले. It's a big fuck. It has to just vibrate here.
That's true.
Yeah.
That's true.
So vibrator in the ears. Yeah.
This is the exact shape of the screw only, sir. That is how it has to go. Show me.
Like this?
No, sir. The other side. Other side around.
Like this?
Yeah, like that.
Okay.
It has to
The
slide into
circular.
this.
Slide into.
Slide into?
Okay.
Into the thing?
Into the thing, into the main.
Into this. Oh, okay.
Oh,
then
okay,
give me
okay.
the two. Then give me the two.
It's
Then give me the two.
Yeah. So it is not on the bone. It has to go on the device, on the
device. Got it. This is 2 or 3?
2, sir.
Oh, it looks like 3.
सर जरा खींचना पड़ेगा मैं पकड़ता हाँ
तगड़ा खेल No, sister. Don't lift. You don't lift, otherwise that screw will break.
इतला तुटेल.
Give me a better forceps. चलेगा ना, but थोड़ा stout है ना. This is much better.
I'll take another one.
Yeah, please.
Ozonic forces है.
थोड़ा लूज केला स्क्रू था.
Correct. Push.
This is the final one, no?
Yeah.
This is silicon. What is this made of? The lift?
Hydroxyapatite.
Poly PEKK. Polyethylene ketone, sir. Ketone.
Okay, got it.
Got it.
Yeah.
So, now you have to use longer screw. दूसरे में है golden color का screw.
Now it won't reach.
Golden screw?
Sir, this is 8 mm length. Earlier we were using 6 mm length का screw.
Wow, ये खतरनाक दिखता है.
Dr. Bhumkar, sir.
Yeah.
Sir, Dr. Gauri Balsare madam from Pune
Yeah.
suggesting that we can fix it with one screw.
It's done.
Yeah, we done now. We got both. That's what the Bedell person said. Even if you get one screw which is very secure, it's good enough. But then the second one with a 2 mm lift we got. I think now it's
and now
perfect.
we use a torque range.
Yeah.
10 to 20.
Okay, sir.
Yeah. So, but they said that one is okay. Even if you get one, they have enough literature to say that one is good.
Okay, sir. Thank you, sir.
Yeah.
Got it. 20.
In the process, I have forgotten how much skin of my ear I have stretched and overstretched. So I have to look. I have to clean it and look at the color.
15, 20?
Yes.
Perfect. Okay.
Now you just move it and see it has to move, so that indicates that it is very secure.
Solid.
Okay, lovely.
Lovely, super.
So the bone bridge is in place. Now we have to get our ear in place.
That bipolar should not be touching the.
Okay.
Monopolar.
So now no monopolar. But we'll have to stitch the soft tissues. No, not required. Suture and drain. Let me do the suturing, hide the framework. There? Yeah. Thanks.
The periosteal flap we are just suturing. Then we'll put the drain and then the magic moment for the ear will be there. Forcep. Somebody.
Registration form.
Yeah, so we will do that also.
We'll do that.
Tukar.
If you want, give it to me.
संबंध कवर वाला पाया. हे पण मागचं पेरियोस्टिन याच्यावर. Correct. Yeah, perfect. Got it. संतोष मी बाथरूम जाऊन येतो. क्या? No. मेरे जैसा बॉल्स किसी का नहीं रहेगा. फर्स्ट टाइम एवर डूइंग फोन फ्रिज. जरा बंद.
This material is Vicryl 30. Ashesh?
Hello.
Yeah, you are using Vicryl 30?
Yeah, 40, I think.
40. Okay.
40. So, दूसरे दिन वाला glove. Sorry, I had taken a short break, so now I only have to put the drain and then my job is done. Dr. Gayatri will take over the suturing and the framework placement. And our sister Sushma, she is doing the periosteal suturing. We have that extra piece, na? We'll put it back. No, no, it's okay. Yeah, we'll see. We'll put it back. Santosh, drain. At some other time, I will tell you what I do for the periosteal flap. I don't make it a actually inferior base. I take a triangular flap. This is what I've learned from my microchears, so that the base is always uncut. So, but I'll need to explain it. Hmm? Hmm. Okay. Thank you. Thank you, Hashim. You're not waiting for lunch, no? We'll catch up. Thanks for coming. And folks, next Sunday. Huh? Yeah. Yeah. Yeah, yeah. Yes. No, they are reaching out to us. Wait till April when that new model comes. Yeah. Oh no.
External device, does he have it?
Where is that? Ganpati, no? What there?
Does he have the external device?
संपदा को पूछ. Okay, bye bye.
ब्लीडिंग है इधर से.
किधर है? ठीक है. वैक्यूम से हो जाएगा. जरा पेन दे पर पटकन पेन दे. Just give me a pen. त्याच्यानंतर कर. Drain, please. तो जर का फ्रेमवर्कला लागू नसेल तर मी परत का वाढवू का जरा दे. आता सला लफडा आहे आता. नाही आहे मला ब्लॅक दे. तर इथे ब्लीडिंग. काय वाढवायला लागेल? स्किन पॉकेट. Now the problem is it's आहे. नाही वाढवायला. I have done it. दे ड्रेन दे. नाही, it's okay, I know.
सुभाष 2 मिनट एसी बंद कर लो.
दे मला अजून दे सीझर फ्रेमवर्क ये दिख रहा है ना
Practically to do with this.
ये इथे जरा गडबड आहे. हे वर आलं याला वर घे स्ट्रेट
बाहेर काढायचं काय ड्रेनला ड्रेनला बाहेर काढू
नाही नाही ड्रेनलाच वर ढकलतो ते काय आहे त्याला खालती सपोर्ट नाही सो इट गोज हे वर उचलल्या जातं साईज बरोबर बनवले ना लावून बघ चल तो इकडे यायला पाहिजे अच्छा
हो मॅडम बघते
छान दिसते ना
हे ते असंच आहे ना
और खुर्ची दे त्याच्या खाली एक हे टाकू का या ट्रेजर्सला वर आणायला
अरे तेजस्वी पण खाली गेलं का
No, not new one. खालती फक्त वेस्ट पाहिजे सपोर्ट चला हे नाही ना इथे खाली सपोर्ट. ठीक आहे हे करते का दुसरा लाईव्ह एकदा त्याचा शेप आला की वी कॅन गो ऑफ. दे नाही दुसरा फोर्सेस आहे. इथे जरा सूचर घेऊ तर गायत्री मॅडम राहायला की करायला किंवा तो सूचर कर साधा वायक्रेलने पण कर किंवा वायरने कर. हे ह्याला वायरने ह्याचं मी थोडंसं स्किन पॉकेट वाढवतो. झालं if people are there, see the skin color is all good. Nothing has changed. At least in the immediate with all the retraction that we did.
Yes, sir.
Another 5 or 10 minutes, we just put the. I was not happy with the way the drain was around. It was too close to the framework. There's a little peculiarity here because his mastoid is so contracted. It is only in the upper 1/3. This lower 2/3, there is no bone. It's all actually the neck. So the framework is going to go dip inside. So when it dip inside inferiorly, superiorly it gets elevated and starts to cause a strain on the superior border here. In the post-op period, this becomes a vulnerable stress point. So I didn't want the drain too close here. I wanted it further away. Therefore, I increased the pocket. And under the tragus, we are adding one more additional piece so that this remains elevated. It doesn't sink into the neck.
So do
That's
we
the
need
sort.
to put the drain right up till the upper part, like, because
So yeah, so now what was happening because of that, the axis was getting altered when we were going all the way anteriorly to go all around in a sort of a semicircular way. In the post-op healing, now we don't, between the side locks and the root of the helix, we don't elevate this skin. Because earlier we used to elevate the skin to accommodate the suction to go all the way here. But what happens is the framework has a tendency to then move like this. So the axis would keep changing. So now we sort of dictate that it cannot move anteriorly. And the pocket has to be airtight. It doesn't matter where. It's quite a powerful suction. So everything gets sucked. There's no need to go all the way here.
sir, can we suture the like the
The
cartilage?
framework, yes, you can. That is also one can see. This is the additional piece that we have added under the tragus. But yes, so good point, Chanel, that it can always be sutured. But what happens is, later on, for the skin, there's a little bit adjustment here and there that we do. So we keep moving. हे मोठी नाही ना फ्रेमवर्क बरोबर साईजची आहे ना तर एक दोन हे घेते का स्टे सोचर या इथून सोचर करा गायत्री ये कर हे वरनं करा just suture the upper first. Hopefully there's no redundant skin and then it becomes a little easier to this is a little vulnerable skin. Then there. नको जाऊ दे No, it's okay. I'll cut it. I'll cut it.
तुला इकडे करायचंय का जा नाही कंटिन्यूस घेते लॉक करून
बस रेखा
नाही नाही सर पाठवते कंटिन्यूस फक्त घ्यायचे कंटिन्यूस लॉक त्याच्यात
ड्रेनला फिक्स करायचं राहिलंय.
बायकरी घे
बरोबर आहे, बरोबर आहे. गो ऑन सुचरी. हे सुचर कर ना मग करू ऍडजस्ट.
क्या चीज है इधर?
This suturing is also with Vicryl 40.
No, this is
No, this is a 6050 nylon.
Okay.
bigger guide because last time the edges were different. आणि दुसरी जी ओल्ड कलरच्या जमत नाही
Needle holder दुसरा.
पिशवात येते
After how many days we can remove the drain?
The drain?
Yes.
About 4 days. 4 to 5 days.
Right.
Yeah, see the shape is coming up. Oh, sorry. So if at all I do a Baha in the same stage, I plan to take a separate incision. This I'll keep a bare minimum. And if I have to do a Baha attract, I'm going to make a separate incision and insert the.
I think that is the right thing to do.
Yeah.
Means it is safer also, because if some infection occurs, then the
Yes. Yeah.
if bad luck is there
The
or
only
patient's
thing,
bad luck.
Deepak, now you know what the new 602 that these guys are talking about. I
Yes.
attended their webinar. Their doctor from Austria says he has done it in a 15-month-old child because it is so
Okay.
slim. So if that
Yes.
happens, then we can start doing the hearing thing early on, and then there's enough 5-7 years in between for even if we take a bigger
Yes.
incision for the scar and the tissue to settle down. Especially in children, I think the skin tends to get supple again.
Now, just I want to congratulate Dr. Gayatri. Now she is so expert. Even
Yeah.
means very few surgeons are means can make this structure like the way she is making.
Yeah.
Actually, great credit goes to that architecture of that uh, ribs and cartilage. That is very important. That is going to give the future shape whatever we do.
Absolutely.
Yes. Yes.
And not only that, it's not just the size, the shape, the size and the height, because
Right.
that decides how much the skin is going to be stretched. Early on, those were the mistakes we were doing. We were
Mhm.
trying to keep the framework as big as possible. And then there was an inadvertent, prolonged, too much stress on the skin, and the skin would break down.
Yes.
So
Actually,
Deepak
Ashish,
has been
we
our
need a full seminar on that framework surgery, how it is been done, because in most of your webinar, we have seen part of it being done.
Yes, sir.
I
Yes.
mean, that is
because
from
it's
start
little
to end.
boring. We can't talk too much during this surgery. There's not much to be told. So therefore, we
Yeah,
like to mask it with something else that Satish or Ashim does, which is
yeah.
interesting. In between, these long pauses are very boring, I think.
Yes, that's true.
That is
That's
the
true.
that is the reality.
Yeah.
What you can do, you can plan only autoplasty workshop or this webinar.
That not 5 people will attend.
Oh, no, no, this is a great thing. I mean, as I told you last time, Ashish, if you remember,
Yeah.
autoplasty, I mean, who that doesn't
Surgery of
come to
the
my
foot.
mind who is doing in such a good number, because one has to really learn and exert, and to come. It is not that I saw you once doing and I start doing and I get the results. So
Yes.
this is still one area where hope for, I mean, some anybody, young people can take up this and they can make a career in that. So
This is the fine job now. This is where actually Gayatri's contribution is much more
yeah,
managing that skin to the final millimeter precision.
yes.
कैसा होता है इसमें? Okay, the entire anterior surface of the lobule is going to go away. Hmm. Should I defat this? So Satish is missing today after 1 o'clock because he's got the cricket finals. That is how we have kept only these two cases today. But next Sunday we shall compensate.
So people should come with a good appetite for this. Usually, this webinar used to run in 9-10 hours.
Yes. So next Sunday we will hopefully
Yeah.
we've got 8 confirmed cases for autosclerosis at our hospital.
Yeah.
2 are standby. There's one 8-year-old with a congenital who's come, but his CT scan is yet to be done. But Ashim has got 4 or 6, and Satish will have as many remaining as possible. Problem with us is we have only one operation theater. So when we did that Stapes Carnival, we had at Satish's place we had 6 OTs. So we could here, unless the first patient is out, I can't do the second one.
True. You can keep on switching over. I mean, once you demonstrate.
Yeah. No. So for that of course we'll do.
Yeah. And one thing, most of the surgery when you watch, it seems so simple because all our people who are demonstrating, they are doing it so nice. To look, it seems, it's a child's play. The truth, fine tuning is when you start doing it, when you face the problem. So that is something, I mean, not in other specialties.
So what is the post-op protocol in such patients?
Nothing. It's just basic wound healing now.
Yeah.
So
dressing is there like on the 4th day when
dressing
you
the second day we open and see, just make sure that the color of the skin is good. There is no hematoma between the skin and the framework. Sometimes the drain can get blocked and stop draining. So if that happens, then we pass a long fine catheter through the suction tube and try to clear it. But pretty much nothing for the first 5 to 7 days. It is only that 7th to 11th day where the skin color starts talking to you or screaming at you, wanting help. And that's when we...
So the patient is admitted for 4 days till the drain is there, or the patient is at home?
No, when they start mobile, typically on the 3rd day they go home. Even with the drain, they go home. Or they go stay in the nearby hotels and, so we give them the IV antibiotics while they are in the hospital, but with the drain, they go home. And children, especially on the 3rd day, they are absolutely fine. The chest is also not giving them any trouble. The first day that they have the trouble with the rib.
So once the drain is removed, when is the next follow-up then?
If the skin color is looking good, then 7th day or the 8th day.
Okay. So the patients who come from far over places, they don't have to come.
No. We tell them that please plan to stay at least for 10 days or 14 days. Ideally, we negotiate for a month. If they are from real long distances, and if we don't have a friend who we can refer them to for post-op care, we insist that and we typically tell them that we'll tell you the return date 3rd or the 4th day after the surgery, because by then the skin color starts giving us an indication that things are going well or things are likely to have a problem. The skin starts to become dark, and what we have realized is not just dark. When it starts to become excessively parched, that is the skin that is likely to break down. Just dark but remaining reasonably moist, still it sort of heals itself. But when it becomes excessively dry, then we know this skin is going to go away.
So at that stage, what do you do?
We wait actually for it to
Right.
physically break down at some point, and then
Mhm.
we tend to do a few things to slice off a little bit of the cartilage to bring the tension down on the skin.
Yeah.
So we sort of put an 11 number blade needle where it is there,
Mhm.
and we see where the skin tension can be released and the edges can be brought.
Yeah.
So most of the time this is enough.
Yeah. No need for a split thickness graft, skin graft, or
No,
anything.
no, no. Split thickness graft does not work.
It is not
If
going
at
to
all
hold.
there is
Yeah.
a larger area than what that TP flap we saw in the morning,
Yes.
that superficial
Yes.
temporal artery, that needs to be brought. So that is why I
But
mark
then
this
probably
artery always.
that probably spoil the beauty of whatever the good work you have done, isn't it?
Not really, because you have to
Okay.
apply a bit of vacuum under that flap also, and
Okay.
then the contours come.
Okay. Good.
But that's really for large defects.
Yeah. And do you routinely use anything like platelet segregators and all that?
No, not routinely.
Yeah.
Our Dr. Subhash now has become a master. When we start seeing a color change,
Mm-hmm.
and if the superficial layers of the skin are not intact, that is
Mm-hmm.
when we are using that PRF, what he showed, Satish once from Jaipur,
Yeah.
from that centrifuge. He's gifted us that centrifuge machine.
Mm-hmm.
And in the post-op period, Dr. Subhash takes out that film that Satish showed from the blood.
Yeah.
After, I believe, 1300 RPM for 8 minutes or 8, how much? 13
Yeah. Yeah.
minutes?
He has shown that machine. I remember. Yeah.
1300 RPM for 13 minutes.
13 minutes. So, any role of complamina tablet or anything like that?
No,
Platelet
honestly,
segregators? No idea,
I have
or
no
never used.
idea. No idea. I actually
Okay.
not used complement in my entire 30 years of practice for
Yeah, it's a
anything.
more of a theoretical, empirical, I can say. I don't know how much work people used to use it for SN hearing loss also, thinking it to be like that. And now it
Yeah.
is, yeah. Mhm.
Actually, I think Ashim has left now. He's not here. But Ashim
Mhm.
used to use, Ashim still uses it in SN loss, I think.
Basically, it is empirical. And see, there are so many factors. I also made a study of around 100 odd cases few years back. And placebo and double control, if you do, hardly any difference. So my conclusion was it doesn't really help. But since it
Doesn't.
doesn't cause a harm and patient
Yes.
has a satisfaction, you can.
Yeah.
So
Earlier, we used not among the parameters. Earlier, the local skin condition, if they have some fungal infection or if they have too many acne, these are
mhm.
the patients that we sort of treat that. We don't operate on them right away.
Yeah.
Just in terms of
Mhm.
what factors can influence the healing or the look of the post-op.
Mhm. I think one more drug I used to use when we used to do for Burgers disease, which are end arthritis, do the amputation and stump. I have worked in general surgery, as I showed you. Percentin used to be one thing, that is the platelet segregator, and that is called. It stops the micro coagulation of the vessels. So,
Percentin.
percentin, complamina retard, these, I don't know whether it is available now or not. I used to use it a few decades back when I was in general surgery. Used to do lot of amputations for the leprosis and
Okay.
Burgers disease and all that. So the healing used to improve by that. And the same logic can be because it improves the peripheral circulation at the skin level or the subcutaneous level. That's why I asked this question.
His skin है जरा extra skin है.
So Dr. Sohail Aslam has a question for you. He's from Karachi. He's asking about the role of steroids and for how many days would you suggest them to be taken?
Steroids in what?
In the healing process post-operatively.
No steroids. We don't give any steroids.
And so Dr. Ramakrishna from Hyderabad is complimenting you for the surgery and is saying great work. And he's
Thank
very
you.
happy that he's attended the webinar.
Oh, thank you so much. I think this is too much. The skin, we are not happy. We are going to trim it off further. There's always a dilemma of how much more to cut or not to cut. But we will tailor it, I think. There are times when you leave small blebs of the skin or blobs of skin, and at a later stage, after 3 months or so under local, you can fine tune them. This is typically when they happen over the antihelix. You don't want to be too aggressive in that area. Or the skin which was draping the deformed cartilage. In our experience, that is the most delicate skin. That's the one which is most vulnerable for necrosis.
Yeah. Actually, some dog ear tags you can leave it for a
Yes,
later stage to
for
be
a later
trimmed,
stage.
because
Yes.
if you trim now and there is some gap, that is difficult to fill up.
Too much, yes, too much, yeah.
Even 1 mm of the skin is very important at times, So
Absolutely right. Because if you get an exposure of the cartilage,
right.
then it's just a question of time that one, it can get infected, and two, it can get resorbed.
And a dog ear like extra skin is never a problem. Even if you do 3 months, 6 months down the lane, what
Yes.
else there can
Just
be a
that on the table, it doesn't look so impressive, the result.
yeah, that's you can say.
But
Yeah,
that's,
right.
yeah. But this is good now. So we have to thank Medal. Medal has been extremely supportive. They have been very kind to give us this device and give a lot of support along with this. There's a lot of back and forth because it was a grossly contracted mastoid. We had their team of doctors actually from Austria also help us in a few things about the planning.
Yeah.
And here I have been interacting with one Mithun from there. I think he's a fantastic guy. No.
How much pressure you maintain for the suction? Is there anything fixed or
No,
just
not really. Now we have come
just
down
you
to this
feel when it is
most
skin is
basic.
touching the
We have
framework?
come to the most basic Romovac now.
Right.
We went through multiple different types of suction drains. And actually now we keep it to the bare minimum. Once we apply our bellow there,
yeah.
Right now it's on the suction machine while she's suturing.
Yeah.
But before that, and then we sort of keep it at the bare minimum that is required.
Yeah. Because the purpose is so that the skin remains approximated to
the framework. Yes.
Right.
That is the important.
You don't want any dead space in between the two.
In between. That's right. Yeah. And we went through a phase of using those molds in the sculpted thing, the hearing aid material. All kinds of things to make sure that. But now, it is very nice. Yeah. So this is good now. मैं करता है पेन दो सर.
Anything plastic surgeons are doing differently than what you have demonstrated?
What? Sorry?
Anything plastic surgeons who are doing orthoplasty?
They're not. Most of them are not making the entire framework. They're still following the Brent technique of doing it in 4 stages. The tragus, anti-tragus, very few that I have seen. So this entire. What happened was actually for the plastic surgeons, this hair and fat became the low-lying fruit.
Yeah.
So even at the World Congress level, there are 100 people who attend, maximum 100. If 100 people attend the World Microtia Conference, it is considered to be a success.
Okay.
It it is that less popular all over the world. So most of the plastics are not.
I think Ashish, you will agree with me. One reason may be of less popularity because it uniformly didn't give very good results. So we,
Yes,
in early part of our career, used to suggest try to conceal it with your hairlines, grow
yes,
hair,
yes,
and it will decrease. And auditory part that is only taken care of. And
correct,
people never approached ENT guys for the reconstruction. They
correct.
always approached plastic surgeon. I have seen best of the doctors, they think it is for the plastic surgeons to do it.
Yes,
And any technique, it is not popular if it doesn't give good result. Had
agreed, agreed.
stepes surgery not given good results, it would have never been so popular.
I totally agree.
Yeah.
Absolutely agree. But then
So
it
we
did
have
not.
to.
So the opinion did not keep update with the development that keep happening. Even today, if you ask somebody, now that we are doing it and showing good results, but otherwise, even now, most of the
Mhm.
surgeons or most of the pediatricians or doctors don't
Yeah.
encourage the parents to take the
Go
kids
for,
to
yes,
go for.
yes.
Yeah.
They say you increase the hair and it will be concealed. What is the
So
need?
our ex-president Abdul Kalam, he
Hmm.
had a deformed ear, and that is why he had that peculiar hairstyle
Yeah.
where he kept this thing hiding the deformed ear.
Yes. Yeah. Yeah.
So this is true. It's there on Google, and I use
Yeah.
it. I use that slide in my talks,
Yeah.
but only for the parents to know that a microtia or a defective ear does not. I mean, you can be the president of India. What big you want? What bigger you can?
Yeah. No, no. Any technique to be popular, it has to give uniformly
Either
good
say, either
results,
city.
and
Yeah,
more and more
yeah,
people should start doing. Then
yeah.
only it will be. Otherwise, it will
Yes.
die down
Laga,
after some
laga.
time. You know. So,
So now we are ready for the final look. Yeah, last.
great.
वन भी दिखता नहीं अभी. It's okay. दिख रहा है? Can you see the? Yeah.
Yeah.
Okay. It's beautiful. All
Contour as
the
well as the color of the skin.
color. Yes. The
Yeah.
color of the skin is absolutely no
Normal. Yeah.
compromise made
Yes.
because of the overstretching during drilling and all. That's all good. Our earlier plan for the bone bridge was here, but now it has come a little bit superiorly. It
Yeah.
does not matter. I
And
can
post-oral sulcus is defined very nicely.
this year
Post-oral
because
sulcus.
not the sulcus. There is no sulcus, but the thickness and the elevation is very good. See,
Okay.
it
Yeah.
is here like this.
Sir,
Right.
So
Ashish,
we'll of course do a second stage because his lower one third
Uh-huh.
is quite deep into the neck.
Right. That
We'll
is what I
definitely
was.
need an elevation later. Yeah.
Yeah. That is what I was thinking of.
sir, Dr. Sohail Aslam from Karachi wants to know
Excellent.
role of steroids and for how many days do you give?
There is no role of steroid at all. I don't know why that question is coming. We are not using steroids.
Yes, yes.
There is no role for steroids in the wound healing of this. आवाज येतोय? Oh yeah. The puncture.
Hello? Hello?
Yeah. Hello.
Sir, we have marked the superficial temporal artery only that as a
Yeah, so that you don't damage it inadvertently.
yeah, you don't go more anteriorly.
More anteriorly. Sometimes it has branches which come down like this.
Yes.
Not in such deformities, but when you have a hemifacial microsomia, the artery runs directly through your surgical field. So
Okay.
there again, like I told, with a 30 gauge needle, you do hydrodissection and protect the artery, and then elevate the skin.
Yes.
See, she's checking what our Sushma sister is checking. There's a small sound, hissing sound. So this is not an airtight. So like a Kerala puncture, we call it. We're putting this little water to see. We can see the movement here. So some stitches will have to be reinforced here because we want a airtight and we want that airtight vacuum there for the skin to not come out. The chest, either दिखाओ. Just वरचं दाखव. This is also done extremely meticulously by Dr. Gayatri. The suturing at the chest. She's gone through a different learning phase for this. दिख रहा है? अच्छा वहाँ पे है. Okay, sorry. Yeah. Okay. Nice. You're going to finish that and then come here.
Just because it's continuous now.
Continuous. Okay. मैं तुला घ्यायचं आहे का? का नको? हाँ. Okay. हाँ. Okay. So I guess we can call it a day. If
Yeah,
Rajiv is
excellent, Ashish. Thank you very much for a nice
Thank you,
demonstration.
everybody. Thank you so
Thank
much.
you. Thank
Sorry,
you so
today
much.
was more like a silent movie and not much talk, but we'll make all the noise on next Sunday. Yeah. Yeah. Thank you so much. Yeah.
Thank you, sir.
Thank you.
Bye. Bye. Okay. Okay.
Thank you, sir.
Ashish was ultimate.
Yes, Rajiv. Thank you.
Ultimate. So both the cases are ultimate today.
Good.
Landmark cases.
Thank you,
And
sir.
thank you
Thank you.
all.
Thank you.
Thank you,
Pooja.
Senal.
Thank you
Thank
for
you,
everything.
Pooja, Dr. Deepak.
Thank you, sir.
Venus is
Yes.
there. Satish is there. Thank you all.
Chanel, Satish is there.
Satish is online, but I think he's
But yeah.
Udbhav is ultimate questions ultimate.
Yeah.
Voilà.
The framework, the microshare has now become a smaller part. It is now becoming okay routinely. Yeah.
Sunil sir, Dr. Sunil.
Thank you so much, sir.
Yes. Sunil, thank you so
Thane
much.
again.
And
Udbhav.
Sunil is running this unique lab. They're doing RT-PCR.
Yes.
Yeah.
Sir, as rightly pointed out by somebody, right? Everybody, when you all have been doing, experts do the surgery, everybody seems like it's a cakewalk. But since you did the surgery for the first time and you had the guts, and you rightly said that you had the guts to show it to the world, so it was really commendable, and it was like everybody could understand what are the intricate difficulties you will face it when you're doing it for the first time. But it never appeared that you are doing for the first time. So it was very meticulously done.
I mean, this is about being absolutely honest.
Absolutely, like, this is how the teaching
There
should
is,
be. Like,
we
everybody should have the
learn from each
confidence.
other. There is no this thing of one is trying to show I am so and so and I have so and so. Nothing.
Yeah, exactly.
So
So
we
that
have
will
comments
like
from
give
all over.
more confidence in new surgeons, budding surgeons, that even when they do those if they have the concepts and the surgical landmarks well, they can take up some new surgeries. They can build up the careers in that, sir.
Yes.
Wonderful day today.
Wonderful day, sir, honestly.
Thank you.
And so, as rightly said, like, the people, all other people, they measure their successes by material milestones. I really believe that you people and you, Dr. Satish Jain, Aap and Dr. Hashim, they really define their success by developing new budding successors, sir. Hats off to you, sir. Take a bow, sir.
Thank you.
Like, it's very difficult for people to, to teach everybody what you are doing and like allowing people to come up in their lives, sir. Thank you so much, sir.
Okay, so all the best. Thank you.
Thank you,
Thank you, folks. Thank you very much.
Thank you, sir. Thank you.